welcome everybody. Welcome to CSEP for all of you who are um, engaging with us for the very first time. CSEP is a public policy think tank, and one of the areas that we work on is health. As part of our work on health, we've in large part been focusing on health systems. And a very, very key component of health system remains HRH, the health workforce, not just for India, but this is something that's a pain point across the world. Pretty much every country is struggling with, adequacy numbers, quality, skills distribution, etc. So this was an important topic. And while for a long time we've been looking at these three elements, I would say, quantity, quality, and distribution, it is well understood that now there are additional pressures in terms of the demographic transitions, which means that there is an increasing senior population. I always use the word aging, but given my gray hair, I think let's use the word senior population. There is an increase in urbanization. There are the pressures of climate change on health. So there are a variety of shifts which are actually adding to the pressures that were already there on the workforce. So therefore, not only do we need to think about the gaps and the challenges that were there till now, but look ahead and see what additional pressures they're likely to be and how are we going to actually solve for them. Now, at the heart of the health workforce problem is medical education. I'm not saying that's a problem, but medical education is very central to the health workforce discourse in terms of the production of the workforce, in terms of the skills that are developed, their quality, and also in terms of the distribution, taking into consideration issues like costs of medical education, and that impinges on where this workforce chooses to work. That's one of the factors. There are many other factors. For that reason, the health team at CSEP has been focusing on medical education. We had an earlier piece of work. Some of you around the table were there for the seminar previously as well, which looked at the demand and supply dynamics. And this is a second analysis, which is looking at the financing of medical education. So the idea is to share our work as well as work done by others. So there's actually a wealth of insights and experience around the table. So thank you for coming. The way that this 2 hours will be structured is that we will have 3 presentations. One is by Rakesh Waghmare, who's Registrar, Maharashtra Medical Council and Officer on Special Duty, Department of Medical Education, Government of Maharashtra. Thank you, sir, for joining us. A second is Aarushi Bhatnagar, Senior Economist, Health from the World Bank. Aarushi was there for our earlier seminar as well. Thank you, Aarushi, for staying with us on this journey. A third one is Amrita Agarwal, who's a visiting scholar with CSEP, and again was part of actually directed the earlier piece of work as well. This current work has been done jointly by Amrita, NITI Rao, and a researcher, Khushbu Balani, who left us a while back, but the 3 of them worked on that. After these presentations, we're lucky to have 2 discussants, Umesh Gupta, Senior Director, HR and Chief People Officer, Max Healthcare, so that we get both the public and the private perspectives, and Sonalini, who I'm hoping will be here soon. She's Team Lead Health and Human and Social Development at the ADB. And the session will be moderated by my colleague Niti Rao, who's a fellow at CSEP. So with that, I'm going to pass it to Niti. Let's begin, and hopefully Dr. Paul should be here soon.
Thank you so much, Sandhya. As you say, we have a lot of experience, and also the subject, I think the measure of interest is exemplified by the fact that we have governments, we have implementers, we have research institutions, and we have development partners in the room. So hopefully we'll look forward to a rich discussion at the end of the presentations. But without taking up too much more time, I think we'll start with the case of Maharashtra and all of the reforms that Maharashtra has undergone in the sphere of medical education. I'll invite Dr. Rakesh Waghmare to please take on the mic.
Thank you very much, respected chair and all esteemed guests here. Dr. Rakesh Waghmare, working with the government of Maharashtra since last 8 years for these policy matters, as well as development of medical education state of Maharashtra. Currently, I am the registrar of Maharashtra Medical Council along with a few other charges. So, with due permission, I will start my presentation. Can we? So, also my honorable secretary and honorable commissioner is. Today they got important cabinet. We are moving one of the important cancer proposal in the state of Maharashtra. So they need to present there for the presentation of that proposal. So I am representing on behalf of them. So I will start. So my presentation will be broadly divided into these 5 components. What is the status of medical education in the state of Maharashtra, as well as what is the scope of our department, what was the vision of our department, what are the recent reforms we have done, and what are the basic challenges we are facing. So if you see this medical education drugs department broadly categorized into into these aspects, that one is the Directorate of Medical Education, another is the Directorate of Ayush, another department is Food and Drug Administration coming under Medical Education Drugs Department. There is also one state institute in the state of Maharashtra, MIMH, Maharashtra Institute of Medical Mental Health. Another Hupkin Biopharma also comes under our department. There is only one government university for the health, that is Maharashtra Institute of Health Sciences, headed by Honorable Madhuri Kanetkar, Vice Chancellor. Then there are 10 councils in the state. One of them is Medical Council. So this is the broad distribution of the institutions in the state. Almost 2,100 institutions are there. 79 specifically for the medical, one of the leading in the state. As well as we have huge number of nursing institutions also, GNM and ANM. So there are almost 2,100 medical institutions in the state. This compromises for more than 1 lakh students getting degree annually. So this is the scope of medical education and related courses in the state of Maharashtra. We can see almost 12,000 students are getting MBBS degree, which is almost 1/10 of the state of the country. Similarly, our contribution in the postgraduate education is almost 5,000 seats per year, in which government contributes almost 2,100 seats. So this is the broad distributions of the state. Overall, we are contributing 10% of education in the country for the medical. Then this is the scope of department. We are having 35 medical colleges working in the state, plus few cancer hospitals, few super specialty blocks, few trauma centers, apart from others, other health units. So 35 medical colleges. One of the oldest medical colleges is the Grand Government Medical College and Said Sir JJ Group of Hospital, established in 1845. So over a period of time, as of now, we are having 35 medical colleges. A catchy point in this, recently in the last year only, the 10 new medical colleges has been started. You can see the serial number 26 to 35, GMC Mumbai to GMC Gadchiroli. So with this distribution, we have presence in each district of the state. 36 districts are there. 35 medical colleges are started. 3 are under pipeline. That is one at Palghar, another at Varda, and third is at Ahilyanagar. They are going to start soon. So as of now, we are impression in the entire state. So this is one of the important for the Maharashtra state, that we have presence of GMC in each state. Few of the districts like Mumbai, 2 GMCs, Nagpur, 2 GMCs, Pune, 2 GMCs. So likewise, we are having pan Maharashtra presence. So based on this, we can take few policy decision pertaining to medical education. We all know that medical education is a subset of the public health. We are not in the command state, but being pan Maharashtra impression, we can take such types of bold decision. Like recently on 9th October 2024, we have launched a cancer organ donation policy initiated by the medical education department. Similarly, today only we are presented one cancer policy based on the Assam Cancer Care Foundation. So that is also one of the pan Maharashtra decision taking by the government. That's why our honorable secretary is busy in that important. So this is one of the important, we can say, a bold decision or lead taking by the medical education, being in the being the subset of the public health. We all know that public health and medical education work simultaneously. Many of the states have a single department, but our state have the two departments for the health. One is the public health department and the medical education department. Medical education department having almost more than 30,000 beds. You can see 22,000. These are only for the medical colleges. Other beds like cancer hospital, super specialty blocks are there. So we compromise almost 30,000 beds in state. And these are all tertiary care beds. So this is a huge number of tertiary care infrastructure led by the state department. So as of now, we are compromising 4850 graduate seats, which is the half of the total UG seats, almost 2100, that is almost 40% of the total PG seats. But we are lacking in the super specialty care, only 77 seats out of total 400 in the state. So that is our one of the thirst area where we want to work more. So this is the just current performance, almost 10 million OPD cases we are seeing annually. Almost 1/10 of all OPD admissions, OPD cases get admitted. 1 lakh IPD is there. Based on this, we are having a number of radiological investigation, lab investigation. So huge clinical data is with Maharashtra, which can be utilized for the policy and various reforms for the country. So just a budgetary outlay that is not that much important, but almost we are getting total budgetary outlay for the state of Maharashtra is say 25,000 crore, out of which we get say 10,000. So this is 5% of total Maharashtra budget. 5% of total Maharashtra budget with state, out of which 25,000, almost 8 to 9,000 we got it. So for the plan component, for the schemes, we are getting almost 2,200, which is substantially increasing from last few years. So non-PAN component, which includes mostly salary, you all know that the salaries of the healthcare professional is huge, specifically the doctor's cadre. So almost salary component is huge in our state of Maharashtra. So the vision is broadly divided into 4 parts. You know that there is a undergraduate, postgraduate, super specialty education. These are the 3 components, and most important component for the medical education is the research that can found the base for the healthcare development. So research is one of the 4 components. So we broadly divide into vision into 2 parts. Each component divided in 2 parts. That is, one is the greenfield project and another brownfield project. This categorization only for the greenfield, that means where we are starting from the newer, totally from the scratch, and the brownfield projects which are already ongoing institutions where we can develop. So first left upper corner shows that expansion of UG education. So that gray color shows that existing medical college can be upgraded by their existing seats. The upper limit for each medical college is 250 students per year. As of now, out of 35, only 3 colleges are having 250 seats per year. That is Grant Medical College, JJ Hospital, GMC Nagpur, and BGMC Pune. So 32 medical colleges still have potential to upgrade from their basic seats. So 3 medical colleges that I told you is the Wardha, Palghar, and Ahilyanagar that we can form. So this is the greenfield expansion. PG education, the recently started medical colleges, if they complete 3 years, they can go for the PG expansion. So recently we started many new colleges. As soon as they complete their 3 years of duration, we will enter into the PG education. That is the demand of the society now. Because if you are looking for, if you are generating 5,000 graduates per year and 2,005 to 2,500 PGs per, that means 50% gap is there. Each and every medical graduates want to become a PG. We also know that the demand of specialization or even super specialty is rising. So this is adding the burden to the graduates also. This is an important point to be discussed, because if you are talking only for the medical education and specifically stuck to the graduation, that is, you are adding some stress to the graduates, because every doctor want to be a postgrad. These doctors are a little bit of cream of society, or the bright students, or a brain we can say. And if you are not catering their need is to pursue the PG education or super specialty education. Being a human, being a society, a human or a person want to show only to the cardiologist for health element, surgeon. They don't want to go to the medical graduates. There is 50% gap in the country also. So PG expansion is one of the important aspect. So that's why we are specifically focusing on the PG expansion. The third most important thing is specialized care. That is a super specialty expansion. That I told you, we are having 400 super specialty seats, out of which only 77 with the government sector. We know that the specialized care like transplants, rheumatology, IVF, these are the rising concern. Man just told that not aging but the growing. So the specialized care is important. So we need to create, the society can only be balanced if you produce the doctor. The available doctor can only be produced by the medical education. They can't be produced by the public health department. So that is important aspect in the super specialization care. So if you see what is the priority, super specialist care is the priority, then specialization, then graduation. This is the priority for our department. So first and most important priority is specialization, creation of the specialized doctor rather than specialized services. If you create the doctors, then only they will give the services. One of the presentation in the past by our own chair, that Paul sir has only presented one of the presentation, that we required almost 15 to 14 years from now to produce the minimum requirement of the super specialist. So that is the demand of the society, availability of specialized human resource. But our mandate is to create the positions, education, then only they can be produced. And the last most important thing is research, medical education, and our department name is DME, Directorate of Medical Education Research, which was lacking. We can say this is totally acceptable thing. Research is not that much because of one of the important reason is we are totally overburdened hospitals. Our bed occupancy is always more than 100% for each hospitals. Our not recognized beds are more than 5,000. Third thing, the doctors are already occupied with services as well as teaching. The research was not there in their service mandate. Or we can say they're already occupied, so they were not able to do that much research. But the most important, we have the huge clinical data, clinical materials, so that can be reduced. The recent achievement with the help of ADB, we can say, we have initiated one of the most important aspect in the state, that is the Center of Excellence for Research. And that is the more credit goes to our honorable VC Madhuri Kanitkar madam, because of her visionary leadership and support from the government of Maharashtra, previous Secretary Dinesh Waghmare sir, current Dinesh Kumar, and our Rajiv Nivatkar sir. Because of this, last year we have launched a Center of Excellence for the Research in the State of Maharashtra. This is unique in the country. The acronym is kept for the Chakra. Chakra is for Center for Health, Applied Knowledge and Research Autonomy. This is the center of excellence which will operate in the hub and spoke. In the next slide, I will show that how is this hub and spoke model is working. This is the most important thing, in which there is a specific center for research. This will coordinate with the medical colleges. The spokes, the specific 7 medical colleges has been identified the spokes. They will work in harmony with the university for research. So I will give in detail the next. But sorry, this is the vision for our department. So I will just show you one of the slide of this. If you see 2014, we are having only 2100 MBBS seats, and 2024, in the next 10 years, the seats has been increased by 4850, almost more than double in the last 10 years. Similar, if you see for the PG expansion, 2014, it was 862, and recently in 2024, 2119, more than double. So this is the recent expansion in the state of Maharashtra in UG as well as PG. So the vision that I told you, that we want to expand further in the next 10 years. So this recent reform, that is one of the most important thing. Recently, last year we started 10 medical colleges that I told you. It is one of the historic decisions in the state of Maharashtra. 9th October 2024, Honorable Prime Minister has inaugurated all the medical colleges, and that was started at a same time. The another most important reform is we required a huge amount because of this expansion. Considering our ongoing trends of budget or budgetary provisions, we will be in almost more than 20,000 crore gap. So one of the assistance that we got from the Asian Development Bank. So Asian Development Bank's total $650 million project is there, out of which $150 million is the liability of the state of Maharashtra. Remaining $500 million we got from the Asian Development Bank. Out of this $500 million, 350 is for the capital construction, work, that is construction, and remaining 150 is for the policy. 7 policies has been formed in this. They are unique policy. One of the policies is the Center of Excellence for Research. Remaining policy, we can say the asset management, talent management, then review of the performance of the institutions, IT development. These are the one of the important other policies of the department. This thing is unique with the ADB, that we also learned. The state has also learned that we can't focus only for the capital. By simultaneously, we should work on the policies also. Then only they can work in this institute can perform better. So as of now, 2 GMCs are already constructed under this fund, that is ADB, Alibag and Sindhudurg. Another 2, Amrauti and Vashi, has been proposed. So another IFC, we department in 2021 has issued one of the important PPP, that is PPP policy, in which we have made 6 models, 3 models for the undergraduate development, the remaining 3 is the specialized medical education development, specialized college development. They called as S1, S2, S3, Medical College 1, Medical College 2, and Medical 3 College 3. These are the 6 models. I'm not going in details. The policy is in public domain. It is one of the important document, 50 pages document for how the government of Maharashtra or any government can work in with this fashion with the private sector. Very unique and beautiful policy. If someone want to read that, based on this policy, we have entered one of the project of PPP in radiology. Then this is regarding what I told you, this Chakra. Chakra, that is spoke hub, will be the MUHS Nashik. The remaining medical colleges will be act as a spoke, but each spoke will itself a unique center for excellence. Example, Grand Medical College will specifically work on the this part, data sciences. BJ Medical College Pune will specifically work for the maternal health. Sambhajinagar will specifically for the geriatric care. Nagpur is specifically for the tribal health. So someone can ask why this is specifically chosen, because they are the faculty available and the institution specifically working in this fashion. So they are picked up depend upon their expertises and available manpower, available expertises. So these are the small reforms, but which are a little bit unique. I just want to highlight the mental health concept in the mental health issue is rising. So we have started this mental health sensitized medical student, resident doctor, this mental wellness. This program is specifically created by MIMH as well as TIS faculties. They have given the talks and they were counseled based on their issues. Similarly, we have started dedicated yoga clinic, EGA's yoga center in each medical colleges. That center can be used for any recreational activities, yoga activities, meditation center, and these activities are routinely carried out in medical colleges. Apart from this, we have started dedicated geriatric clinic in each medical college. These all initiatives happened in the last 6 months only. Then what I told you just, we have initiated the organ donation policy in the 9th October. The policy is also a unique policy in which the work is defined into two departments. One is total health department, another is the or interlinked department. Example, higher education department, then school education department, other departments which can also. Sir.
Apologies.
May I just take 5 seconds to
Continue. Why don't you just continue?
just 5 seconds to welcome you, Dr. Paul. It's an honor to have you chair this session. We've had the privilege of Dr. Paul chairing our previous discussion on medical education as well. Dr. Paul needs no introduction. I think everybody in the room knows who he is, member of NITI Aayog, and sort of the driving force for most of the, I'm tempted to say, policy reforms in India currently. Welcome, sir, and grateful for having you join us.
So, good afternoon, respected sir. It's a pleasure to present in. So recently on 9th October 2024, we have launched this organ donation policy in the state of Maharashtra. The work is broadly divided into two departments. One is the totally health related department, medical education and health, and another by other departments work with the organ donation. So in this, we have proposed the critical care medicine department because it has come to the notice that if you want specifically work for the organ donation, there should be dedicated department, say critical care medicine, so that the identification of the potential blood donor and the potential donation can be done. For this also the infrastructure is required. So we have created specifically NT-ORCs to all medical colleges, and some of the medical colleges among this we upgraded to organ transplant center. So as of now, 7 colleges has been proposed for organ transplant center, and remaining will act as a NT-ORC centers. So these are the all outreach activities as department has started from the last 2 years. We have taken 7 specific missions so that the students as well as the faculties will go into the field. They will have the basic assessment, data can be used for the research, as well as these students will get the community exposure apart from the routine community medicine exercises like blood donation drive, organ donation campaign, breast cancer awareness statement, obesity awareness, thyroid mission, oral health mission, cataract. So these are the recent achievement in which almost more than 8 lakhs population has been approached in the last 6 months for this community awareness activities. Recently, for the digitalization, this is also one of the important aspect in the ADB in which digital health. So we have started the student life cycle management system. This will be done with the help of SIDAC, in which all the as soon as student will enter in this medical education, as well as he got the bond, complete the bond services or got all the degrees, he will be managed through the student life cycle management system. Everything will be on online. So another, we have recently inaugurated with the help of Honorable Chief Minister, 17th April 2025, we have issued that blockchain certification, because it has been noted in the Maharashtra that various nursing cadres are producing fake certificates. So this linked with the NIC system. So a blockchain certification will be there. So the authentication of the degree will be maintained. So these are the few proposed projects by the state of Maharashtra. We are in the engagement with Zyka for the proposed financial assistance. Almost 7,000 crore project can be 7,000 crore budget can be seek from this Zyka. As of now, the PPR is under upload and it is under final approval. This will be specifically for the capital infrastructure, construction of medical college as well as the equipment supply. So what I just told that Honorable Secretary is in the cabinet meeting for this proposal. It is under final approval. It may get approved today. It is the MahaCare, Maharashtra Cancer Advanced Care, in which we are proposing L1, L2, L3 cancer care hospitals on the basis of Assam Cancer Care Foundation. They have this L1, L2, L3 model. So we have L1, that is Apex Cancer Care Facility, which is already in the state of Madras, Tata Hospital. So remaining L2, that is advanced cancer hospitals, will be at 9 location. The remaining L3, that is the remaining of medical colleges, that is L3, daycare cancer hospitals, will be at the remaining GMCs. So this is one of the important project under final approval. Another, these are the few projects we submitted to Government of India for under central sponsored scheme, like UG college. Recently, what we started the medical colleges, the funding is proposed under central sponsored scheme. Similarly, we have proposed for the PG financial assistance for the PG disciplines. Some cardiology and neurological unit also proposed under NPCD, NCD program. Another is the level 2 trauma care center also proposed. So these are the few projects proposed to the honorable central government for the approval. So as just I told you, our contribution to super specialized services is a little meager compared to the specialized and undergraduate services. If we see, we are contributing almost 10% in the country's education in MBBS and MDMS. But DMMC, the contribution is less. As we can see, 4,800 seats of DMMCH in India, but Maharashtra 404. And out of this 404, Maharashtra state hospitals only 77. So our contribution is, that's why our first priority among our 4 pillars is the super specialization care. Just I told that in one of the presentation of Vinod Paul sir has stated that 15 to 45 years will be required for the super specialization care. Based on this line only, sir, just I want to make one statement. Sir, Saurabh sir was our secretary. He always mentioned that so we have kept this in our presentation that considering the acute shortages of super specialists in the in the country as well as state of Maharashtra, the foremost priority in the medical education is to creation of the super specialization. So our one of the priority in super special care, that's why we have proposed some of the direct projects with the state, that is critical care medicine, few through the PPP like cardiology and this.
Thank
IVF.
you very much, Dr. Rakesh. I think this is a very comprehensive presentation. Thank you for sharing in detail all of the, the different. I think I wanted to highlight a couple of things before we move on to the next presentation that we can come back to during the Q&A later. One is the sustained prioritization of medical education and how closely the public health department and the medical education department have been working on this. The second, as you just mentioned, is emphasis on specialty care, which clearly Maharashtra is able to do given the progress that it has already made. The third, I wanted to remind the focus on research, which you mentioned. I think that's something very laudable, and the Chakra model sounds very promising. And there might be additional questions about sustainability and how that will be ensured. And with that, I think this, hopefully we can come back to some of these issues during the Q&A. But I do want to go on, in the interest of time, to the next presentation from Amrita Agarwal, who will talk about specifically about the UG situation based on the research that we have undertaken here at CSEP. and looking really at the more global picture and what sorts of emphasis potentially states ought to do, governments ought to do, and maybe some of the examples are already there for us to learn from Maharashtra. Over to you, Amrita, for your presentation.
Thank you so much, Niti. And it was wonderful to see the Maharashtra presentation. Lots of great learnings for the rest of the country. So, and we'll touch upon some of those areas in our presentation as well. We had done a similar seminar on supply demand of medical seats in India 1.5 years ago. Just recapping some of the earlier points, there is lot of effort on expanding medical seats in India, especially on the UG front, but also on the PG front in India. It's grown at 100% plus in the last few years, largely with the government effort. So if you see across most of the states, it's the government which has really been expanding the medical seats in India. Having said that, the gap between the demand, which is the aspirants, which is the students, as well as the need for medical care in India, which is the number of doctors, continues to be there when it comes to the supply of medical colleges. And it's not only in the terms of number of seats, but also in terms of the quality of medical education, which is out there. So a lot of great efforts, union governments, state governments. In fact, the private sector has been a little bit more muted in its participation. So between 2010 and 2015-16, you saw private sector expanding. And then post that, the participation from the private sector appears a bit more muted. But having seen a lot of the efforts, we still see the gap. And we are still not talking about the big global opportunity of demand for doctors in the world. We keep saying economic growth is important. Health could be an area for provide. India could provide doctors for the world. I don't think the medical education system in India is sort of set up for looking at that opportunity. So both the domestic situation as well as the global situation, there still continues to be a huge gap. Uh, we'll try to look at this effort now from a financing perspective and less about the supply and demand dynamics alone. When you can see what is the average expenditure for training a medical student worldwide and how that has evolved. So in 2008, this is Frank et al. Paper. It's not our original work. It used to be around $122,000 PPP 2018 terms. It's largely remained flat in the world. Like it's gone down. So either the world has, and we still need to understand that they've innovated, they have brought in efficiencies, tools to sort of bring down, stabilize the cost of medical education. India, the cost of medical education was lower. The cost of manpower is lower in India. So it was around $35,000 in 2008, but it has increased to around $70,000. So, we are either improving on quality and therefore we need to make more investments, or the costs are increasing and we're not innovating enough to sort of keep up with the efficiency measures. So those are questions rather than, ready answers we have. When it comes to affordability of being able to train medical students, India is still a much poorer country. So a per capita GDP, less than $2,000 in 2018. And the cost of training one student around $70,000 on an average, it's almost 30x plus of what is a average per capita income in India. Whereas in other countries, the multiplier is like 5 or 6. So for the country or individual households to be able to afford medical education, though the cost of medical education training in India is lower, the affordability is still a problem because we are just on an average, the per capita income is much lower. So this is a challenge. So as a country, can we afford to train all the doctors we want to train is something which we should think more about. And therefore, what can we do in terms of economies of scale, innovating on the cost further while maintaining quality? And that's the juxtaposition is something which we need to debate and discuss as a society. We started by looking at government medical colleges, and the data was not very easily available. In Maharashtra, thanks to the government of Maharashtra, puts out a lot more data about the medical colleges than other states. So we're not singling Maharashtra. It was our a pleasant surprise to see a lot more data which Maharashtra government is putting out. And what we looked at was what is the expenditure on medical education across the different medical colleges in Maharashtra. Maharashtra is one of the states which does very well in terms of production of doctors. And in fact, they are net supplier of doctors. So students come there, study, and we had seen in our earlier paper that they go to other states to sort of practice, which is great. We don't expect every IT services engineer who trains in Bangalore to stay in Bangalore. They also go to other countries and states. So Maharashtra is a very important engine for production of medical doctors. And we looked at the expenditure which is happening across different government medical colleges. You can see that, it's rank ordered in ordering of quality as well as by chance, by age of the institution. So some of the older institutions have more established practices and a better branding, and therefore maybe are able to attract more doctors. But you can see there's a stark difference in the expenditure per seat, per medical seat of older, better established, potentially better quality medical colleges like Grant Medical Colleges you were talking about, versus some of the newer, more established Jalgaon and all, which are just coming up. So they're able to also utilize the expenditure and the resources available to them to, actually invest in the doctors using the equipment and the supplies. Whereas some of the newer medical colleges may have shortages of faculty, may not really have processes, and we see that they're not able to sort of the expenditure per seat is much lower. And we had also seen that their newer medical colleges, especially in remote areas, tend to have a lot of shortages in faculty. Medical education is not a curriculum-based system; it's a apprenticeship-based system. So where do we produce best quality doctors and most effectively is often where existing good doctors really are. And I think that's the challenge to sort of consider. When we look at the production function forever for on the other side. So if you see Grant Medical Colleges, the bed to seat ratio is around 11.6 versus say a Jalgaon is at 3. So the government of India policies allow for a bed to seat ratio of 4.2. So a 4 versus 11 means that the Grant Medical College can produce far more because the ratio goes down, the number of seats goes up. So they're allowed to produce far more seats at the ratio of 4.2, which is the permitted number. But the cap of 250, which is, typically in India, post 250, it's not allowed, constrains the ability of Grant Medical Colleges, which is one of the older, more established, best doctors to be able to produce more students. And when we see globally, which you will see later, there are no such caps. And the other question is, while Grant Medical College can potentially produce more doctors using its leveraging its knowledge, why are they not doing it? So that is the other question which we need to consider. So as a state, whether the state should invest more in Jalgaon, do we expect shortages of doctors not to exist? For example, we saw in AIMS, all the newer AIMS continue to have shortages of doctors. What is the quality of the doctors we'll end up producing versus, say, some of the older established medical colleges? How do we scale up production there? The other point is around subsidization of costs. So in Maharashtra's case, we saw the medical fees collected from the students formed only 10% of the overall cost base. So there's substantial subsidization of the costs by the state government, and maybe some in some certain cases by the union government. It is not targeted. So there could be rich students from affording families, and we saw that affordability is a problem in India in terms of per capita income. They may end up being subsidized, whereas there'll be some poor students but meritorious students who then get a chance in the private sector but just cannot afford the private sector costs. So the subsidization of the government is not need come merit based, it is supply side based. So that is the other thing to think about, given the affordability of students. On the other hand, when we look at private medical colleges and what is their incentive to participate in teaching, and this was something which we debated back and forth again because very little data is available, we looked at if the private medical colleges were to rely only on medical fees to get profits or to cover their costs, how attractive is it? And we try to sort of get data from larger universities, deemed universities like Manipal, larger hospital-based colleges like Apollo, versus smaller dedicated medical colleges which get set up as a medical college largely. And you can see that there's a lot of incentive differences between the two different categories of colleges. The smaller medical colleges, which are largely dedicated to being a medical colleges, almost 40 to 50% of their revenue comes from medical fees, not from the patients. And this is estimation modeling of the OPD revenues and the IPD revenues, and therefore it's a estimation. We can discuss that later. That changes the incentive model for them. So for them, the teaching is the primary source of revenue, not the patients. So they may not invest in quality of the treatment of patients or attracting patients. They often are the ones, which we know from anecdotal qualitative interviews we have done, are not able to maintain the utilization levels or quality levels. And when the inspections happen, then they sort of make their effort to sort of do that inspection efforts. But they are not primary hospital. They're like a quasi university, private college. But the larger ones, it is not lucrative enough for them to sort of be a medical college. Less than 10% of my revenues will come from the fees, even though the private medical colleges charges much, much more than the government ones, like 10x more or 8x more. Even then, it's less than 10% of my revenues. We don't have good data on the cost side, but I suspect the costs required to be spent on running up private medical colleges is much more than 10%. So it's almost like a loss-making proposition. So if I'm a private sector, with all the norms which I need to meet, the libraries and the utilization norms, it's very hard to meet 80% utilization in a large private hospitals. Most of them run at 65, 70%. So when you look at the costs, if I have to comply with all the norms and the friction of complying with all the norms, it's much more higher than what I will get as revenue. So what is my incentive to sort of scale up is not clear at all. And that is, the point we're trying to sort of understand is what is the incentives of various actors in this system. So, we observe that there is a cycle. So, there is all these large hospitals who just do not have the incentive to participate, as we saw on the previous page. Revenue is not high enough. The costs and the frictions of complying with the norms are very high. The small scale private hospitals are very eager to participate because it's maybe viable to be set up as a dedicated medical college, but they don't really have the patient load or the quality or the branding to sort of attract patients. So the teaching of the medical colleges is poor. The government imposes stringent norms to quash the low quality medical colleges, which makes the large hospitals even more, saying that we can't comply with these norms. So it's a cycle of lack of participation, which we observe on the private side. And again, some of these things we're hoping we'll get into more dialogues and research. This requires more primary research in future, which I feel like it's a very important area for us to all do. Now, what does this all mean in terms of scaling? Finally, while we talk about quality, we have to worry about scaling our efforts for meeting domestic and global demand. So what you see on the left small table is the government norms, and we can look at the 2020 norms because the 2023 norms are not yet in force. Around the beds to seat requirement is around 4.2, for different sizes of number of seats, 50, 200, 200, 250. So that's the ratio which the government permits. Now, when you see on the middle table is the private hospitals. And how to read the table is the different rows are the different hospitals by the number of beds they have. And the different columns are the bed to seat ratio. So, and the numbers which are filled in the color coded cells are the number of hospitals who fall into that category. So above 900 bed capacity and falling into the bed to seat ratio of greater than 5, there are 56 private medical colleges. What this means is that these 56 medical colleges per se by government norms of 4.2 can actually add more seats. So the ratio instead of 5 something becomes like 4.2. So it's not even about the regulatory norm. The norms are too strict and we should not, we should lower the norm from 4.2 to 3. They're not incentivized. They're not even, going up to the permissible level of scale. And similarly, on the government side as well, we see 112 government medical colleges which are operating at a ratio, bed to seat ratio of greater than 5, when they are allowed to sort of scale up more, but we are opening newer medical colleges which are smaller in capacity, in newer remote areas with smaller number of beds, which are not able to meet the bed to seat requirement, assuming the bed to seat requirement is a proxy for quality. So there is a challenge we see both in the government and the private medical colleges. We are not able to leverage our large hospitals, which potentially have the best doctors and the best practices and the most complex cases to teach both UG and PG. So, given that this is important. Yeah, so that's what we are saying. Smaller hospitals are not able to meet the norms, and the larger hospitals are not interested in, even going closer to the norms. They're not interested in scaling up, or they're not able to scale up. We try to look at the global medical college scenario because, there's this debate about quality and affordability in India. So we looked at top 30 medical colleges in the world, and we tried to look at what are their models. And you see that there's a huge variety in the top medical colleges. In terms of scale of beds they have, some have very large number of beds, 7,000, 10,000, 8,000. Chinese medical colleges have like 15,000, 20,000 beds. And some have very high number of seats, like University of Washington has 1,000 plus students, whereas others have 200 in Sweden per batch. And the bed to seat ratio is widely varying, 2 like 7, and there's no consistency. So there is no correlation of input measures to quality, assuming that these are top medical colleges and you can eyeball some of them, and they seem to be in their variety in terms of number of attached hospitals. We also have some variety in terms of attached hospitals. So the point being that the inputs are less, we think, a proxy for what is quality. It's the incentives for people to sort of be the quality wants to scale up. And then for us to be able to do output-based quality assessment, which, for example, in US, Canada, and other countries, there's more emphasis on. And India is also trying, but we are leaning still more in terms of input-based quality measures than output-based quality measures. That's really the challenge. Almost concluding in the next few minutes, we spoke about quality, and there is a lot of effort on output-based quality assessments. There's more funding required, more effort required on this. So on Maharashtra, you spoke about research, and this is a very important point we saw in the US consideration. Almost up to 5% of the budget for medical colleges in the US comes from research grants from the federal government. That will attract top physicians, top doctors to really participate if it's linked to them also teaching the students. So if you look at the DHR budget, research budget, or DBT or DST, one, the budgets are low. Two, most of them go to dedicated research institutions. They're not coming to medical colleges. So there's a delinking of research money used to attract and incentivize top private or government medical hospitals and doctors to participate in research and also linked to teaching. So we don't see that linkage in India. And I think that program which you now have in Maharashtra is very, very valuable for us to explore this linkage. So the 4 policy recommendations which we sort of thought about is, one is on government medical colleges. We should prioritize scaling up of capacity of existing good quality government medical colleges, not only leaning into the new remote ones. It'll continue to be very difficult to attract good patients, practices, doctors really in the remote areas, but there's scope to scale up existing large government medical colleges. On the private medical colleges, we need to think about the incentives and the frictions of large private hospitals to scale up production. And Dr. Gupta, it'll be great to hear your views on this. So medical research grants and increasing the subsidization for adoption of AI and technology for teaching. We have to look at the cost curve, how that can come down for teaching is, I think from the government side, could attract the private sector even more. And we have to let go of the input-based regulation even more. Fund output-based regulation a lot more. There is a lot of efforts right now on this front. We just need to double down and get more budget going into it. And this lastly, on affordability of students, and I think the World Bank team will talk more about it. we need to target the subsidies, not make it supply side based on government medical colleges, but make it need come merit based. Doesn't matter the students are going to government or private medical colleges. Where the students can afford, they should pay the full fees. So I'm going to pause here. Thank you so much.
Thank you, Amrita.
Clarifications, not question, clarifications. When you say output-based regulation, can you give some examples?
Yeah, maybe Niti, you want to talk about?
So actually,
Just for our, because
so we
Dr.
did look at.
Gangadharji is here, and we can both conspire for some good things. So let's hear what we mean by that.
So we did look at. So firstly, to say that there are a whole bunch of levers potentially that we can look at when we look at the quality of the outputs, or rather the outcomes more correctly. And there are two levels at which that can be looked at. One is the quality of the graduates themselves, so the individual students that come out. And of course, there are measures like the exit exam, for example, that's already supposed to be in place potentially. And there can be more thought about how that can be a better measure of quality. The second is about the quality of the institutions.
If the bad bunch of students come out, you cannot course correct it.
So only the
So
ones.
what you're saying is that you allow us to do what we want, but we'll have great doctors coming out.
Yes.
Then
basically.
the damage is already done.
Well, it's one time.
No, give me an example. This is practical.
So different countries
आप बताइए क्या करते हैं?
have been doing a mix of different models. So they have very broad criteria, similar to, broad inputs like similar to what we have. And then they look at very closely the process measurements. So they monitor the processes very closely, and there are dedicated committees that are set up, which are a mix of, very trained experts who actually measure each of the processes. And there are periodic sort of monitoring measures that are happening throughout. And at the end, the graduates will only be qualified for practice if they actually qualify based on whatever the accreditation measures are, and including these quality measures, unless, for example, in the US, unless you clear that exam, which actually is a mix of not just a written one, but they also measure on how the bedside manner and other things like that, the practical aspects. Unless that happens, as you know, they are no longer, they cannot qualify to practice. So that's a way in which it is closely linked. So the regulation of medical education is closely linked to the regulation of medical practice, and that linkage helps to ensure quality.
Example where from your very excellent, superb work that you've done, and I had a draft report also. Give a practical example that change this. This is redundant. Give me 3 examples, and we are hearing.
So Dr. Paul,
and we can have some input. Let's be specific. These supply side regulations, 3 examples are useless. And then where you think our monitoring is actually, I think the way you're explaining is so much more monitoring out there. We don't monitor, then every day there'll be so much of pressure of NMC on every college. You'll cringe. So just give me example of 3 things that you want to see changed for the so-called input based regulation.
Yeah, so the couple of input based regulations which we don't see, there's no golden rule for why that number should be that is, teacher to student ratio. It has been relaxed.
Okay.
The bed to seat ratio norm, we saw that there is no basis for it.
So
There's a huge
teacher to, but no, let's be specific.
teacher to student ratio, bed to seat ratio. I think the requirement for the library and all has been reducing, and the space, infrastructure space, because for cities like Bombay, it is very expensive. If you go to MIT,
library,
yeah,
what else?
physical space. So these 3, for example,
We'll come back.
these are input based.
I want to
On the
preempt. We'll come back.
Yeah, absolutely.
Okay.
Thank you. Actually, I think that in itself is an area of interest.
Question was this clarity on why private sector, sort of, behaves in a certain manner, and you pointed out the fact that there are disparities of what small ones can do, what the bigger ones can't do, and that will help us understand these dynamics. You talk to the small time medical college private, what do you call, the promoter, okay? Promoter comes into your room and then say, oh, everything is bad, you control us too much, this, that, and it's very difficult to reduce fees, so many expenses, this, that. So when we would ask the question, actually it's reflected here, but I am bringing a perspective of a conversation. They'll say, when we put this, very difficult to manage. So I say there are two parts to your work. One is you have a hospital, which is supposedly an entity that should generate money, right? Then there is a college part, and then the hostel. Hostel is self-supporting, let's say, where inputs have to be made, which is like an engineering college part, maybe a little more, maybe a little less, right? So I would ask them, how do you run your hospital? Do you make profit? So the answer I get from these small time players, the ones who are the biggest defaulters, is we run the hospital on the fees. What is this? We don't want that kind of a system. No? It's fundamentally flawed. You cannot run hospital on fees. You must make money, at least some equipoise there. So this design that people got used to has been at least partly responsible for kind of a, like a totally unacceptable fees level. But then I'm now challenged by the other argument that you brought. This I can understand. Now you're saying that the large hospitals which are financially viable, they don't want to do college. You're saying because the regulation is stringent. One moment, we can make it easy. But they don't want to also do it because they don't need to do it. They think they're making business out of it. Why should they have, students coming in? That bill is not there. 3 years ago, 2 years ago, sir, you'll remember Dr. Mansukh Mandviyaji, when Honorable Health Minister, we made a very, pointed effort to reach out to specific hospital chain and say, can you make medical colleges? Please, you are running so well. It was there in the newspaper also. And we said, we can have you tied up with people who can do the, sharing of labs and this, that. And we didn't find attraction. The short point I'm making is the ones who run great hospitals do not want to run a medical college, the UG type, okay, MBBS. The ones who are small, their maths runs in such a deviated way that they want to run the hospital, which means just minuscule, that you said very correctly. On the fees, their whole motivation will be to make money. So they will neither run the hospital nor give medical education. That's what they're doing. So kindly, this has to be understood in that perspective, because fees continues to be a very major issue. But we're happy to listen to pathways to make hospitals do undergrad. At the same time, the large hospitals should do a whole lot of PG courses through the national board system. And now also we are opening doors through the NMC system. And that's a different conversation, because you hardly need anything more than a good running hospital. There is practically no requirement. And then also they don't come forward because they have to pay that resident, because that resident, as a junior resident, as an MD student, is also serving their business purpose, and they don't want to pay. So we'll come back to this. I'm only saying a few triggers. We perhaps
Maybe
could
we can
return to
invite-
this, because to us, these are, I don't know how to get out of this, please. But over
We have
you,
Mr.
over to the
Umesh
agenda.
Gupta from,
Just a trigger from our side.
sir, we have Mr. Umesh Gupta from Max
Yes,
Healthcare.
yes,
So
we'll have a conversation.
So I think.
But let them complete the agenda. Maybe, one by one, we can take it up. I have all the time, right? Because this kind of a meeting is really
actually,
music.
why don't we finish this thought? Because I think we'll be moving to a
Yeah.
slightly different theme with
No, we can.
Dr. Aarushi Bhatnagar's presentation. So maybe I'll.
Also, I think.
अब करिए सर, बात करें.
So, as far as I think very, very insightful, you can say presentation from Amrita. And I just wanted to highlight from the private player, like first and foremost for the DNB program, as Dr. Paul has said, I think there is no as such stringent requirement and norms. And I think most of the large hospital, they would like to have DNB student. I think the perception which I think government has is not the right one, that they don't want to have DNB student because they have to pay the stipend. It's not, because there is a huge shortage of junior doctors in all the hospitals, and then all hospitals struggles for either senior resident or the attending consultant level of doctors. And when we are going to have the DNB students, there is going to be continuity of the services. That's how in most of the large hospital they have, like for example, in Max Healthcare, we have around 800 DNB students across Pan Max. This is not a small, you can say, DNB seats. I think for the DNB students, we just have to see, there are norms which are slightly, you can say, uh, slightly rigid on their part. That is, how many seats are allotted based on the, you can say, the professor, what is the occupancy, and so forth. There are lots of things which we can relook at it, and that's how I don't see that that large hospital would shy away while taking the responsibility of having more even super specialty and super specialty seats over there, because the kind of work in the super specialty which private hospital today is doing is a phenomenal one. Whether I'll talk about the cardiac, neuro, or GI, or whatever like specialty we're talking about. And second thing, I'll come back on to the graduate one. The first and foremost, mostly all the large hospital are whether they are limited company or they are the private limited company. I think their purpose is not for the, their purpose is for the profit. And the major thing, while they are running the hospitals, which is for a profit center, and the medical education still in the norms, I think to my knowledge, we can only open the medical college under the section 8 of the company, or in the under the trust, and this is a non-profit hearing. And then there is a conflict, because they have to invest the money to building a medical college. And definitely when the investors have invested money and the purpose of the company is to profiteering, and then if it is going to invest, if they go to board, if they go to shareholders, they will never get the approval. And that's how the first and foremost is, our aim should be the produce the quality of medical students, as well as we can have the regulation on the fee structure and affordability and everything. But as far as whether it's a profitable or non-profitable, that is one thing. Because first and foremost, if I'll go, because every hospital, large hospital chain, would like to get into the medical education, because they know if they are going to expand so much and there is so much of shortage of medical, you can say, students, they definitely would like to be the partner. Like in the last 20 years, the IT, they have actually, the industry has partnered with the education. That's how we are able to grow. And similarly, for the large hospital chain also has to come up with this. But first and foremost, I think whenever you go to board, whenever you go to shareholder, there is a initially conflict. And while they are going to invest the money, there is going to be profit and there is going to be non-profiting. This is first thing I would request. Second is, most of the large hospitals are having the hospitals in the metro and the tier 2 city. And when we are talking about the infrastructure norms, when we are talking about the 20 acres of land, for example, today we have in Saket, we have a 900-bed hospital over there. Can I have 20 acres of land in the heart of like Delhi? And if I'll spend that much amount, if I'll invest so much amount of money for 20 acres of land, that's definitely not going to give us the return. So we have the hospital. Can we get the relaxation norms? Can we have the hostel outside from the premises? Can we have the hostel 15 kilometers or 20 kilometers, which is not so expensive? So I think those are the norms as far as infrastructure is concerned. There's some relaxation. The larger hospitals would like to have relaxation on those. Definitely, we don't want to compromise on the quality, and that's how. And no large hospital would compromise on the quality of the you can say students or the quality of the, because ultimately they are also going to get suffer if we are not going to produce the quality of students. Our quality of care is also going to go down. But definitely we should not compromise on the, you can say, library or the lab and so on and so forth. But we should not also stringent norms that this much acre of land, then residence of the faculty residence has to be within the campus only. I think that's how you want.
Thank you, Mr. Gupta. Just wanted to say that some of these are already being considered. Some of the norms have been now relaxed by the NMC, but I think, yeah, there is more to be thought about here. But I did want to move from, we've heard from the government perspective, we've heard about some of it, what the government is doing, at least in Maharashtra. But I think we should, hopefully with Aarushi's presentation, we'll also hear what the students want, what the recent graduates and the medical students, what their perspectives are and what they're looking for in medical education, just to make sure that we have a balanced discussion. So over to Dr. Aarushi Bhatnagar.
Thank you. Thank you for inviting us and for letting us share some of our recent engagements on the issue of strengthening the health workforce, especially medical and nursing education. I'm going to talk about a study that was done as a part of our engagements with the government of Tamil Nadu and government of Assam. These are part of lending engagements that we've had with the states over the past few years. I'll speak a little bit about what we did. Share the context in which this work was done, and then get into few of the findings. There's quite a lot of rich information here, and I'm happy to share the reports with everybody. But I think just in the interest of time, I'll really highlight some of the key takeaways. Before I get into that, though, I do want to acknowledge that I'm actually speaking on behalf of a very large team that produced this work. We have our partners, the Novo Nordisk Foundation, who are here, but we also have research partners. And most importantly, I'd like to acknowledge our colleagues in the government of Tamil Nadu and Assam, especially those in the Department of Health and Family Welfare, and particularly those in the Directorate of Medical Education, who were really partners in producing this work. So what we had sought out to do, and again, as a part of supporting governments of Assam and Tamil Nadu in strengthening their medical and nursing education systems, we wanted to understand the experiences in the preparation for and admission into medical and nursing institutions in the states, both in the public and the private sector, and then the subsequent entry into the job market. We wanted to collate experiences on the quality of education that was received and the perceived job readiness that the students faced. And we also wanted to understand from students their future career choices and preferences and job attributes that they were looking for. And finally, we measured both the private and the public, or the social economic rate of return to education, just to understand some of the investment value that was attached to this education. I won't get into the details, but essentially, like I mentioned, this was done with 3 groups of students: those who are aspiring to enter medical and nursing education. So these are high school students in class 11th or 12th, current students from medical and nursing institutions, as well as those who recently graduated within 2 to 5 years. And we included educational institutions both in the public and the private sector in both states. In Assam, there are no private medical colleges, so there we only had students from the public medical colleges. We used various research techniques, both quantitative and qualitative. We also did something called the discrete choice experiments that allows to elicit at least stated preferences in a manner that you can weight which combination of attributes of a job could be more could be more attractive to those who are aspiring for them. Maybe I know actually a lot has already been spoken, but I just wanted to provide a little bit of context as to why we did this. Of course, everyone here knows that, India has been on a series of health sector reforms over the last 20 years. These have gradually led to a substantial expansion of health service coverage, but it's also led to expansion of financial protection. And all of these reforms, in many ways, really do rely on the production and effective deployment of a well-trained health workforce. And while today we're focusing on medical education, I did actually want to put it on the table that that's only one part of the health workforce. And it's really important to think about the health workforce in its broader sense, to think about nursing education. And this was also a humbling experience for us. We were trying to understand medical and nursing education together, only to come out of this work to really realize that there was a glaring gap in our understanding by not looking at the allied health workforce, right? Because that's really the health workforce, parts of that health workforce that are required for meeting both current but also future health needs of the country. So again, I mean, there's been a substantial increase in production of medical doctors, both for undergraduate and postgraduate levels. And this has reflected in the availability of the health workforce itself. These are some estimates that we just produced based on the periodic labor force survey data that's collected by the Government of India. And that does show a substantial increase in all cadres of the health workforce, and especially the medical cadres. Having said that, some challenges do remain. There are sectoral imbalances, there are geographic imbalances, imbalances in skill mix. You can, when we compare India to other countries, both in our neighborhood, but also with higher income countries, there is a lot more potential for India to improve its production of high quality health workforce. Another important thing that we looked at, and I won't really touch upon it as much today, but again, I think it's one of those things to keep in the broader vision when we discuss medical education, is a gender dimension. And actually, we explored this quite a bit through the data that we were analyzing to see what was the gender composition of the current workforce, what were the disparities, whether it was in working hours or wages or we computed a job quality index to see what were the disparities in that, and we found quite a few important insights. But what I did actually want to say here and to highlight was that having a medical education actually really increases labor force participation for both men, but substantially more for women. So I think here it's a really important opportunity as we discuss reforms in medical education to think about what it could do in terms of its multiplier effects on creation of jobs, and especially creation of jobs for women. So just with that background, I'll get into what we heard from the students that were interviewed as a part of this process. I think firstly, and this is, I don't think this is news to anybody in the room, but entry into medical education is highly competitive. From amongst the students that we spoke to, I think only current students, it took them more than 2 attempts on average to get admission. Only 20% in Assam and 30% in Tamil Nadu succeeded in their first attempt. Almost all students mentioned requiring external coaching in order to get through these examinations. So again, an important insight, which is very well known, but it did allow us to sort of put numbers behind that, at least in the context of these two states. What we did hear from, my first bullet, sorry, I jumped over that, but what we did hear from high school students who were preparing for especially medical education, the NEET examinations, I think we heard substantial challenges regarding a mismatch in the curriculum of what they need to do in their class 11th and 12th, and then what they need to study in order to get admission into medical colleges. In the states that we did this, there was a reported language barrier, which I know has subsequently, there are policy recommendations to change that. There is an opportunity cost because, like I mentioned, right, if it's taking on average 2 years to get admission, then it is an opportunity cost of lost years, whether it's in terms of studying something else or getting a job and contributing to the economy. And then there's, of course, a lot of stress and anxiety that was reported as a part of the process of both preparing and taking this examination. And I'll talk a little bit more about that. Coming to the point of affordability, this is something that we also saw from the data, that a large proportion of those who were admitted into MBBS programs in the two states, both in public and private sector institutions, came from schools that were in English medium. Their parents were educated beyond class 12th, and the average annual household income was more than 8 lakhs. So in general, they were coming from higher socioeconomic status. So there is an argument here that access to medical education may not be equitable. In terms of, I'm sorry, I'm focusing, oops. Can you help me go back? Sorry, this is, okay, sorry. I'm speaking mostly for medical education, but we have parallel findings for nursing education, which I'm not really discussing now, but I would be very happy to discuss those as well if that's of interest. But in terms of medical education, we heard from students the need for increasing capacity of the institutions. The competency-based medical education received mixed feedback. I think on one hand, students reported that they appreciated the focus on skills, the 15 days process of onboarding, the emphasis on non-clinical skills, the complementarity between what was taught in the classrooms and what they were trained on in labs. But on the other hand, they did also talk about the lack of facilities, the underpreparedness of faculty, a short time in which a large part of the curriculum had to be covered, and a mismatch in the formative assessments and the final university exams. We did actually also speak with faculty from these institutions to corroborate some of these findings, and we heard a fairly similar narrative, which was that even faculty themselves felt that they were rushed to cover these subjects. They felt they were inadequately prepared to teach the CBME effectively. They themselves needed continuous assessment and capacity building. And they also mentioned struggling with using newer technologies, and especially AI, which today's generation of students use as almost a default for their learning techniques. Dr. Rakesh spoke about mental health. Very happy to hear that the government of Maharashtra has a program dedicated to this, because this was not something we had originally planned to cover, but it was government of Tamil Nadu that was interested in understanding this. And I think it was a very right decision on our part to include this. And again, this is self-reported. It's not a clinical assessment of mental health conditions, but we did hear from almost 10% of the students who were part of this study that they had been diagnosed with some form of mental health conditions. So this does, at least at the very least, warrant additional research to understand what are some of these challenges, why are they happening. The other concerning part that we heard was that only a small fraction of these students had sought professional help on having this diagnosis. I'll go a little bit into um, the exit from the teaching institutions into labor markets. And if there was one finding, I think that I would say is the cornerstone for us from this work, is that less than 1/3 of the current medical students reported to be fully confident at the time of year 4 or year 5 of the MBBS program. More than 90% of them wanted to pursue further education to enhance their job readiness and employment prospects. And if they could not pursue this postgraduate education, a large proportion of them did mention leaving the profession altogether. So I think that, while the preference for specialization is perhaps warranted given the emerging health needs, from the other side, which is the investment that's going into this education, the fact that a large chunk of students don't feel job ready or would rather leave the profession if they didn't get further opportunities to study is a concerning finding. And I think in both the states that we've done this work, the state governments have taken these findings under advisement to see what can be done to improve the quality of education so that students are not leaving not feeling job ready. I mentioned that we did a set of discrete choice experiments. These are ways to elicit responses from students on what could be a combination of job attributes that attract them to take on a specific job. We did different permutation combinations. I don't have, unfortunately, the time to get into it, but I'll maybe talk about a couple of key things. In a scenario where we asked current students what they would like to do 2 years after graduation, and this scenario was particularly designed to bear in mind that 2 year period is typically when undergraduate students are studying for postgraduate education. We asked them what they would like we gave them different attributes in jobs, and what came out most strongly was a job that allowed them to prepare for their postgraduate education. So I think it didn't matter, salary wasn't as important, location was also not as important. It was really that they could study. So they basically had a balance of providing, working in wherever they were working, but really having time to study so that they could appear and get admission into postgraduate education. We also had a second scenario where we asked for 5 years post graduation, assuming that this period they would have at least either secured admission into postgraduate education or would have completed it and would be in service. And it's there that we really understood a very clear, strong preference for hospital based roles, for public sector employment, and for home state employment amongst medical students in both states. And of course, this has policy.
What did they want?
They wanted hospital-based roles, so not primary
What
care.
was the offer you made? 5 year?
5 year, 5 year after graduation, and the options were tertiary or secondary hospital roles versus primary, along with ranges of salaries, public sector employment versus private sector employment, and employment in home state versus outside. And what came out in these various permutation combinations, I think the most important one was hospital based specialist roles, followed by public sector employment, followed by home state. It's a little different for nurses. I think it's very important. I don't have a slide, but maybe I can talk about it. I think for nurses, we heard a preference for public sector employment. I think that was the strongest attribute, followed by specialist roles, followed by proximity to hometown, and that was linked to their conditions for traveling to their place of work. And I think that's again a very important gender dimension to keep in mind.
Was there an option of specialist?
Meaning a role in a tertiary or secondary care facility. So not an MBBS, but a specialist role where they're providing, they basically are not working as medical officers, but they're working as medical specialists in tertiary. These are MBBS students. They're not these responses are from students. No. This is asking them for their preferences for when they graduate. Yeah, so this is all, these are experiments, right? These are not real life situation. These are just asking students what they would want. And it's a technique that uses different attributes so that we get a sense of relative weights to these attributes.
Was there an option of going abroad?
No, so these discrete choice experiments were based on a fair amount of qualitative work that went into it. And at least in these student bodies, we didn't really hear that much inclination to go abroad. So as a result, even for nurses, in these, there was preference for specialization and for higher education, but not as much for, which, I mean, that's something that we're happy to discuss because that doesn't seem to be the anecdotal sense, right, from some of the states, especially for nurses. But in this particular case, at least in this student group, we didn't really hear that. So we didn't include that option in the discrete choice experiments. I'll end with this is my final slide, but I'll end with sort of us trying to do some measurement of what this investment benefit, what the cost benefit ratio was for medical and nursing education. And we actually found, as one would expect, a fairly high benefit cost ratio, which means that these investments are resulting in lucrative employment opportunities for both doctors and nurses. The economic rate of return is high, again, for both cadres. Um, of course, in the public sector, the return is higher than in private sector, and that's related to the cost of education. Interestingly, for us, we found, I was looking up our numbers, we also found the cost of education for medical programs similar to what you had found, but for the private sector. For the public sector, it was much, much lower, like almost a tenth lower. That's the fees they're charging for the effective cost for the state. This is private cost, so the cost to students, yeah, are not sure cost to the state, yeah, yeah. So just to say, but in terms of cost to students, it was fairly comparable. But when getting education in the private sector. So I'll just end with a few takeaways and suggestions. I think the first important thing to say is that given the health sector reforms, given the expansion of health coverage in India, there has been an increased supply of the health workforce, but there are still opportunities to create more and better high quality jobs for within the health from the growing need or demand for different emerging health needs, especially long term care. Um, there's also a big role for the private sector, not just in training, but also in hiring, that can be leveraged for this potential to be untapped. And then, of course, there is a global demand for medical services by Indian health professionals and medical value travel in India, right? These are, again, two really important, these are two important avenues for increasing jobs for those who are coming out of these education institutions. Again, there's a strong economic rationale to increase the supply of education, but from what we heard, we feel that it's equally important to focus on investing in quality of education, perhaps also in the modality of training, diversifying training to align new models of care. And while the CBME has been a great start, at least for medical education, perhaps there's more to think about this, and not just for medical community, but for other cadres as well. There's also a role for the education sector to play here, and I think this came from our work with the high school students, where there was report a fair amount of reporting on lack of awareness, and this was more for nursing, but even for the medical students, right? So I think for the role of the education sector, the education schools, or even the coaching classes, for providing the right guidance, counseling, I think there is a role for them to advocate for careers in health, especially amongst nurses as well. Then finally, I think given the preferences that we heard for future doctors who are currently studying, and what we see as policy objectives in India, there does need to be an alignment of job packages. So I think, and this is, of course, it this depends more. I mean, this is a contextual decision making. So, I think not for us to decide here, but for different states to decide for their context, or different institutions to decide for their specific needs. But there is a conversation to be had about the roles of specialists and super specialists versus those who may be required for primary health care. And these are not necessary. The answer doesn't have to be medical doctors only. It could also be nursing or other allied health cadres and so on.
Thank you, Aarushi.
That's it.
I think what's interesting is this idea of return on investment coming both from, of course, the private sector, as well as, in fact, from the students who are actually making an investment into their education. And I would argue also potentially for the government about whether the governments are getting the most bang for buck in terms of the investments that are being made. But with that, maybe I'll hand it over to Dr. Vinod Paul for his comments before we open it up to the Q&A to the audience. Over to you, sir. Sure. So then maybe we can hear from the room if there are any questions, any points that people would like to raise. The mic will come to you. Dr. Gangadhar, please go ahead.
The permission of chair, I'll make a couple of observations. I had to leave because that's the reason why I chose to comment first. Good discussion, good inputs, some good learning for regulatory bodies. Couple of observations for this year's statistics. I will tell you so that you can perhaps understand what direction we're all going. This year, about 95 applications have been received for new medical colleges, of which 30 are from the government and 65 or so are from the private. If that explains whether it's an incentive or not, you perhaps can understand it differently. And this is, I'm talking of UG, I'm not talking of private, not talking of the PG. Second thing is, amongst the PG, UG applications, colleges who have sought for increases of seats, there are about 120 private medical colleges have asked for increase of seats, as against 40 medical colleges who have asked for in the government sector for increase of seats. So much for whether education is an incentive or not in the private sector. This year's statistics. Okay, there are many reasons why this could have happened. It's true that on the insistence of various stakeholders, the regulatory bodies have relaxed several components of rules, and which perhaps might appear that the colleges now can be run, and undergraduate courses can be run without such a great degree of financial stress. This is my one interpretation. The second observation is the beds required 3 beds, 4 beds, 8 beds. This is a very which statistics we saw about US. Mind you that the requirement is different from what is being provided. I think what you read out are what is provided in terms of numbers of medical seats vis-a-vis number of beds in that given hospital of a medical college. If that range is also true here in our country. For example, there is a medical college, I don't want to name the medical college, a government medical college, which has as many as 7,000 beds and running 250 seats. Now, okay, you can always say if you had allowed more seats to happen, they would have admitted more undergraduates. We did not put that ceiling on PG. We did not put the ceiling on PG. The PGs run in that college are about 260 or 270. Vis-a-vis that 6,000 or 7,000 beds they have, they could well be producing close to 1,200 PGs. And whatever was the reason why they did not increase is necessarily not the regulatory conditions on which they did not go beyond 250. they could have surely done for the PG, and today we need more PGs. Third point is the recent statistics that we have had. UG increase to that cap of 250. If you take the percentage of colleges which have reached the 250 in government and in private have about 2 times more numbers of colleges, even by that percentage, who have touched 250 vis-a-vis government. So this is some statistics I thought I will share with you. And the point is, after MBBS, what? Now, it is true that numbers of students passing out in a given academic year freshly, who will be eligible for PG, leave the backlog apart. Today, we have 1:1 seats available. That is, for every freshly passing out person, there is one postgraduate seat available today. But it's true that we have a backlog. For various reasons, seats had not been increased, and people want to choose their own subject. They don't want X, Y, Z subject. These are all choices that make this backlog compete with the freshers, which has been a concern that we have to overcome. What if we produce more PG seats than what the UG seats have? Take, for example, we have 1 lakh seats admitted this year. 5 years later, 1 lakh students are going to come out. I could theoretically go from now almost 80,000 seats to 1 lakh 20,000. But still, this backlog will be there. So let's say I go up to 1 lakh 50,000 seats. What are I going to do for those unutilized seats 10 years down the line? Why was this investment made? This question crops up. We have to find some answers. So this is a practical difficulty which we probably have to overcome at some point of time. And I totally endorse that private sector participation should be very much available. And I'm sure, as you are aware, 3 things have happened in the last few years. One is the DNB processes where private sector participation in specialist production has been focused on, which has taken up, and like a point was made, 800 PGs are being prepared in some of the private hospitals without, again, serious investment, having to build a building, undergraduate, etc., etc. Even the NMC also has actually taken this note of the DNB products specialists are now free to apply for faculty position. Job opportunities are there. Those who were teachers in the DNB sector can now become and claim that experience as teaching experience and make a career in medical education in the NMC sector. So in other words, we are joining hands and working with equal participation, both the private and the government. That's precisely what is our intention as well. And the last point I think I will make and stop here. A comment was made by the Maharashtra government in the numbers of colleges amongst the 39 colleges, 3 or 4 only have the 250, whereas the rest could go about. Even going by the number of beds available and number of faculty available, which is what is the minimum required to run a given seats for the UG, corresponding PG occupation has not been there. We have taken this statistic for a couple of subjects. With no change, the beds are same. We are not asking them to add beds. We are not asking them to add faculty. There are, at least in 2 specialities, between 40 to 45% increase of PGs could have happened in the medical colleges, which is true. And with the Postgraduate Medical Education Board having put up some new relaxations and reforms. For every UG, for the departments of UG that are required, if you cover the postgraduates, you can get one PG for every UG student. Mind you, there are as many as about double the numbers of departments which are not necessarily required for the running of the UG department. Assume that they also add the UG, PG courses. You could probably be creating almost 1.75 PGs per UG seat today. The whole issue is mental health points was raised. I am being a psychiatrist, I'm totally aware of these mental health concerns. One of the serious concerns of the mental health issues that crop up in residency programs is overwork. Like he was saying that there are more beds, I haven't increased the PG. I've had the same number of faculty which are required to run my undergraduate course. And undergraduate course demands maximum 250 beds for, let's say, Department of Medicine. I could well be running the Department of Medicine with 400 beds. And the government says you are a 250 bed medical college, you are eligible only for 16 or 17 faculty in medicine. Whereas to run 400 beds, I would probably need another 15 people more, and that is not given by the concerned government. And not having given, to run the 400 beds, I run with lesser number of PGs because I have less number of teachers. So put together PGs, sir, I think this is a very serious issue. I've had statistics data with me. I can even present this. If only all the government hospitals running medical colleges with high numbers of beds increase and utilize all beds for PG production, we probably would have reduced the mental health stress on them, produced more PG people, and better care for patients in the hospital, and more satisfied patients. And the last reform that we have brought, which is to augment medical education, is that he was saying 3 years you need to wait to start the PG. We don't need. At least in the government hospitals, government medical colleges, this experiment has been tried out this time. If you are starting a new college, you can concurrently start both UG and PG. But this is an experiment we have started with the UG, with the private in the government colleges. If we are successful, if people are able to reach up to that, maybe we can go. So this is another reform that has been done. The last reform I think I need to mention is, earlier you need to have 300 beds to start a medical college. And that has to be increased if you have to increase the number of students. Now, even a hospital which has 220 beds can start UG and can independently also start PG. This is a facility that we have created for the government. And this experiment, if this works, probably we will open it out. And why did we do this? Why did we do this? Instead of concentrating in an urban area with a huge hospital and every patient having to come to hospitals of the medical college, run two businesses, service and training. And if services are not distributed to the rural masses where there are smaller hospitals and not improving their conditions of the hospitals there, services will be jeopardized. Improve the quality of care and improve the number of staff available, and that would support PG education. So more PGs can be produced by this experiment. So put together, we have to have two focus. One is exploit all clinical services which we have not exploited. In government sector alone, we have exploited 40% of the clinical services for medical education. Still the potential of 60-65% is still untapped. This is number one. Use all specialist people for medical education in the government sector alone, because I have done just the statistics. I don't have the statistics for the other. In the government sector alone, we have used the specialists, 50% of the specialists as faculty, other 50% are running as specialists, non-faculty. We have now made a new change that even they can be appointed as faculty if a medical college or a medical institution is starting. So use all clinical resources, use all specialist resources, and we can perhaps get better output of the numbers of people whom we are producing. The last point is the process versus product. This has been a preoccupation in the medical education for little more than 10 years. One of the ways in which product can be evaluated is an exit examination. And we had universities in each state which are formed for medical education, and they were monitoring the education. And in fact, they ought to monitor the education. It is a university business. It so happened, in addition to one central university, exam would be conducted in many other private universities as well. So the uniformity was difficult by the state university department. And so the NMC, when it was formed, the national exit test was conceived. I'm sure that one would probably make sure that this product evaluation gets better. In fact, many people have been telling me if NMC has to do the work and the only work, and the only work forever is the national exit examination. Although I'm emphasizing it in a dramatic way, I am also perhaps beginning to understand this concept of product evaluation. We say input and process evaluation. Input and process evaluation is going to be met with a lot of other social, political, and other economic concerns. And if I focus on product alone, then all these variations, like what we saw in US group, where 1,000 beds, 20 students, or 100 beds, 50 students, this is possible. This is a different issue. The process can be variable. Each person can have his own ingenuity to train the people, but I make sure that the product evaluation is very uniform. This is perhaps we probably haven't reached that state of whatever want to call it, sophistication in terms of our evaluations. Admitted students vary from rank 1 to rank 12 lakhs for 1 lakh seats. This is an area I think we need to ponder over. Right now, we have 12 lakh people getting qualified from a 25 lakh seats for a 1 lakh, 25 lakh applications for a 1 lakh seat. In most places, about 3 times the number of seats available is the rank which is made eligible. For various reasons, we have gone up to 12 lakhs. So this is another area, unless, like my colleague keeps telling me, medical education has 3 components: a fertile land, the medical college and the hospital, a good farmer, the teacher, and a good seed, the student. And here it is the seed where from 1 lakh to 12 lakhs. This is not something that we have been able to control for whatever may be the reason. If we can get the best among the students who are passing the entrance examination, we probably could have a better output than what we are anticipating. So the 3 components are equally important. We are focusing on the best college and premises, to some extent the best teachers. Best teacher commitment is a different story, and I cannot force the teacher to be committed. College resources, yes. Student, yes, we can force. If all 3 are put together, strengthens the medical education, which is a quality education that we want. So thank you for giving me this audience.
Thank you, Dr. Gangadhar. I think we're nearly out of time, but I do hope that everybody will get a chance. Please do pick up a copy of the R paper, and we'll be happy to facilitate, the other studies as well. And any questions that come from the audience, please let's keep. Clearly, there is a wide-ranging conversation, a whole bunch of different issues to be discussed, and potentially the researchers in the room will be able to pick up some of the areas that have already come up for future research. With that, over to you, Dr. Paul, our chair for today, to provide your insights and also maybe give us some future directions.
Regarding I have one question regarding the targeting that you were mentioning, targeting of subsidies for the students who are of privileged background. And I mean, after MBBS from government medical college specifically, they are assigned to a certain number of years of rural and semi-urban setup of training and internship and those kinds of things. So, in the event of having that, do you still think the targeting of the subsidy is necessary?
Amrita, maybe before you answer, there was one other question. Maybe let's take that and then we can have the answer together.
She said 1/3 of the students who passed out, they said they were not confident, which is a very, something that tells us about the quality of medical education. And I know the NMC initiated the competency-based medical education way back in 2019. But from my experience, we've started doing some work on, trying to improve the quality of skill-based medical education. The simulation labs was to be set up by the NMC, and I see that, they are being set up at different levels. But, setting a skill labs is easier, but making the teachers, confident and competent to, use the skills lab and that is a big issue. And I think that is somewhere where we need to also really look into how do we ensure that a lot of students will feel, yes, I know the knowledge part is there and they're very good at. So that's why, they're always, but when it comes to the skills, I have heard, people saying, they have passed out without touching a patient, without seeing.
Thank you
You're
much.
talking about- So I think these are some of the issues which needs to be, and I think if you have some data, that would be
Sure.
Thanks.
One last reflection and then we'll ask for quick answers from Amrita and Aarushi.
So very quick points. I think one, Dr. Paul, you had a point around outcome-based financing. I know there is a very high bar in the government on outcome-based financing. We have to look at not doing evil outcomes at certain places versus very good outcomes at others. So one thought there was, can we have outcome-based scaling at least of the medical colleges if we are not going till the financing? Second, I think we were doing a study in Bihar, for example, some of these new medical colleges which are coming in tier 3, tier 4 towns are really struggling to operationalize in terms of faculty positions getting filled. So I think worth giving a thought in terms of what are the reforms we are thinking in terms of whether compensation or whether it is research opportunities for the faculty to be able to get the faculty in some of the newer, smaller medical colleges. And the last thought was the seat mix within PG, and we were working with government of Maharashtra. I think even the utilization of PG seats by different courses varies a lot. So as India's disease burden and some of the other landscape is changing, I think another thing that we can focus on is what should our PG mix look like few years down the line, and maybe there is an opportunity to keep updating that. Thank you.
Thank you. And I'm going to hand it over to the panel here, but just to say that please do catch hold of the speakers, and of course we can keep the conversation going in other forums. Amrita and then Aarushi and then over to you.
Very quickly on the subsidy. So, a student from a 50 lakh income household background versus a 2 lakh income household background going to government colleges, both doing the same rural service is not the same thing. There could be differential level of subsidy. So I'm not advocating for zero level of subsidy. And that the reduction in subsidy to a higher income student can then be repurposed to a 2 lakh income household background student who is getting a seat in the private medical college but cannot afford it. So
But if he then denies to do the mandatory internship or mandatory 5 years of that, so are we able to trade off that? I mean,
yeah,
is
so we
that
have to
trade off
study
for
this
what?
in terms of economics and trade-offs. I'm sure that it is so lucrative with the government medical colleges, the ratios which Aarushi showed us, that even with a lesser subsidization, any high-income person will love to go to government medical colleges. Good government medical colleges is prized by every student in India. So the level of subsidization is not the one attracting a high-income household student to the government. So I feel like this needs a little bit more careful economic analysis to come to the right level of subsidization. And it will just make the government subsidy more effective to help other low income meritorious students. What you were saying, between the 1 lakh and 12 lakh, there could be very good low income students which are not able to sort of make it to a seat today. So we need to do a little bit more deeper analysis to sort of get to the right level of subsidization.
I'm going to ask you to take it later.
Higher income level students are not incentivized to go to government medical colleges.
No, they are going. They love. I have family members who.
No, if this scenario appears, then that will become like that, right?
I'm going to take this as a sidebar and hand it over to Aarushi.
Thank you. Just maybe I'll come in on that because we do actually have some data, right? Like the students that we spoke with came from higher socioeconomic households. That they elicited in the discrete choice experiments were for public sector employment. So I think just to answer that question from this limited data that we did find, that remains a preference. And I agree. I think there is a need for a lot more detailed economic analysis to understand costs and benefits. Like what we showed was a very rudimentary analysis of costs that the students paid and what they what they would earn based on some market research. But I mean, the way we actually do cost benefit analyses, where we look at health impacts as well, like that's something that I would really encourage researchers around the room to consider doing if it hasn't been done already. So to answer your, I'm so glad you're raising it because I think that was one of the central messages of this work. And I think that quantity aside, a very concerted focus on the quality of medical education needs to be provided. And like I said, the study was done in partnership with directorates of medical education in the two states that we were doing. And I think for them, these were really important findings to take back to their to their decision making and to the institutions that come under them. But to give you an example, I think there are some really important efforts that at least we're aware of through the programs that we're engaging on. So, for example, the government of Tamil Nadu has come up with a statewide continuous professional development policy for its health workforce. And, there they are building a digital learning management system, which will over time also start looking at some of these issues that are missing from today's faculties knowledge repertoire, right? Because for example, they started with a course that was mirroring the EdCom course because those who are currently in service, when they studied MBBS, that wasn't part of the curriculum. So, they're sort of providing that as in service to both the faculty and also those who recently joined service. The government of Assam, for example, has come up with a roadmap for its nursing cadre, and they have a lot of I would say a lot of these findings have gone into thinking about what kind of nurses would they like to produce. What's the right balance between nurse specialization versus not? What are the roles? What kind of investments are needed for the faculty in terms of improving simulation labs or other faculty development opportunities? So I think there is a lot of work that's happening, but quality of the education sort of uh, needs to come to the forefront. I think that perhaps is still not
Thank you.
quite there.
Thank you. Over to you, Dr. Paul.
Thank you very much. Lavish in absentia, Sandhya ji, Amrita, Aarushi, Rakesh, all the distinguished colleagues. Um, it's the kind of meeting that I truly enjoy. One, I feel at home. Second, I get ideas to work on and really to hear the voices. Thank you. So thank you Sandhya, for the opportunity. Quickly, because a lot has been spoken and Gangadhar ji has given important perspective already to you. So I'll build on that. But so in quick succession. Firstly, we need more doctors and we need more specialists. Have no illusion that we are close to being enough. Today, we have 14 lakh potentially, as per the government data put in the parliament and so on, 13.86, let's say 14 lakh doctors. That's 1 per 1,000, the so-called WHO ratio, which is for the world, not for rising India, not for a developed nation and aspiring to be a developed nation. That is the ratio which is for, let's say, African nations and at some point relevant to us. So no question that 1 per 1,000 satisfies us. Number two, developed nations typically have 3 doctors per 1,000. We may have views on how to do task shifting and that, but then to work with something close to 3, and many countries have 4 and more, it's a reasonable goal to work with. So 3 Is the goal? Shall we say that we will do that by 2040 so that health professionals and health sector becomes engine for achieving the goals, because health is an enabler. It's also economic, shall we say, paradigm and power, or economy generator. But above all, healthy people are required to be able to push the frontiers of nation's growth. So let's say 2040, 40 lakh, that's about 3 times the number. You add Ayush, which is about 7.5, they also become 3 times, and then the population would have risen. So you do all this maths, we'll be targeting to something like 3 per 1,000. It's a reasonable goal. So let's remain focused on that, number one. Number two, we definitely need a stronger pipeline and a bigger pipeline and a more generous pathways to address that pipeline for the postgraduate specialists and super specialists. Sir has highlighted, and some of you who have heard me are fond of sharing some data on this. I'm pulling out one slide here. Some of you may have heard. Let me repeat. So this is Dr. Venkat, my OST, Brigadier Venkat, who has done this work and still relevant. Let me pick up general surgeons, okay? Our annual supply is about 5,500. It's 1 year old, so maybe some augmentation. If we are LMIC, their ratio is 22 per 100,000. We are 9. Okay, and to reach LMIC, 34 years at the current pipeline, or let's say last year's pipeline. To match high income countries, 69 years. And general surgery, so much of waiting, so much of more to happen, so much of unmet need. Let me pick up psychiatrists, okay? Psychiatrists. Current ratio 5 per lakh. LMIC is 15. One moment, that's psychiatrist, sorry. Current ratio 0.7. LMICs, they're generally thin and anemic. 2, that will take us 12 years. High income countries, 13, because those problems become major. So you may not target 13, that's not the issue. But if you look at them, 13, and our pipeline is about 2,000 seats, it'll take us 23 years. I can go more on this some other day when Sandhya ji gives me an opportunity to do the talk rather than only comments. So have no doubt on this one. Cardiologist, I'll say LMI, you may like to know, that's your favorite. Okay, 6 per lakh. We are 0.7 per lakh. 82 years it'll take for the current pipeline. Obviously, this will change, but this is just to tell you that you have to work hard. And work hard systematically both on the NBE pathway as well as on the NMC pathways, and I'll come to that. So पहली बात settle हो गया कि बहुत अभी कुछ करना है. आज हम nursing की बात नहीं कर रहे. And second part is quality. We'll come back to that, and then distribution. So let's keep in mind. But pipeline होगा तो आप distribute करोगे. If you are poor, what do you distribute? Poverty. So if you have a few doctors, what do you distribute? So let's be very clear that this push that the Honorable Prime Minister has brought about is historic, and you have heard the data that 130%, more than double, okay, 130% increase in UG seats, 135% increase in PG seats is what you have witnessed it in your, in front of yourself. That's first part. Second, several reforms have happened. It hasn't happened just because people are coming and saying bana do. वो भी हो रहा है. But there are reforms, and you heard some of them. I'm not repeating, but please understand that huge effort has been made. For example, now you heard from sir that PG program can start from year 1. When I was chairing the BOG, I brought it down from 4 years, or perhaps 4 years, to about, I think, 2 years or 3 years, right? But now we have the confidence to push it right away. So those things have been done. Very dramatic improvement in faculty eligibility, very liberal. And some are saying perhaps too liberal. Yeah, now we will say too liberal. When you want, okay, when you're on the side, say, बहुत tough बनाया हुआ है, अब थोड़ा अलग कर दिया तो DNB experience is being counted for faculty. Specialists will become faculty, and so on and so forth. So we are on the liberal path. And I want to put on record that today there is no stipulation for 20 acres. In fact, there is no stipulation for any acreage. If I can, I want to read that just to Umesh so that you, and please spread the good word. There is the current MSR, which is 2023, which actually we had crafted, but NMC promulgated. It only says every hospital seeking to be a medical college. Sorry, 1 minute. I just want to read because let this be known everywhere. Maybe it is not known. Shall comprise of the teaching hospital, etc., etc. Each unitary campus shall have adequate constructed area of land as per the prevalent building norms. For the college, building norms for the hospital, there is no acreage. You can have 2 campuses, only condition 30 minutes travel time. 30 minutes can mean, 1 kilometer in Bangalore and can mean 20 kilometers. So the time has been put. So the short point is now the functionalities are being expressed, not the the mathematics of it. So that's gone. That era is gone. You can have 2 campuses, and I think the Hill we have 3, because there are 3 types of things. You have residential, you have the college should be compact in some place, hospital should be at the heart. I want one big message to go out. Heart of the medical college is hospital, hospital, and hospital. The problem occurs in the minds of some people, that the ones that I referred to earlier on. They think the college, so-called college, okay, those laboratories and classrooms are a medical college. And some people spread the rumor that the cost we do very cheap because they don't add the cost of establishing the hospital. आप समझ रहे वो ये कहते हैं इतना पैसा क्यों लगता है? They forget that the requirements that are put in the guidelines are to be able to run the hospital, that you have so many beds. पर जब उन्होंने बताना होता तो ये कहते हैं कैरेमन आइलैंड में तो सिर्फ इसको तो मॉल में आप लगा सकते हो. So that's the college part. College is not medical college. The so-called college. College is the hospital. And for postgraduates, actually, you need no classroom. You teach around the bed, you teach in the OT, you teach in the casualty, you teach in the most critical situation, the ICU. Just need a room for residents to sit down and sleep, and they're working hard. So ये सारा demystify हो चुका है. We like the good word to spread. Yes, for the 250 students, you do need a place to be able to address. That happens in management, it happens in art, it happens in engineering, and that's what it is all about. Point has been made, not so much these days. Faculty बहुत कितने टीचर क्यों चाहिए? I did a simple maths. You look at the IPHS norms for a district hospital of say 400 beds. That requires about 90 clinicians, right? Because it's all clinicians. For a medical college, actually you need less for the same number, technically, okay? But you do need for the pre-paraclinical another 30 people. That is the level of rationalization that has been done. The core issue is that the faculty, clinical faculty that you need is just to run the hospital. These fellows are so committed that not only they'll run the hospital, but also teach the students in the same period of time. Somehow they'll adjust. That's how we have worked entire life. We were doing all the clinical work, and then we'll find enough time, more than enough time, to teach the student. That's why we don't work 8 hours, we work 16 hours and 14 hours. So isko demystify karo. It's running the hospital is the heart of undergraduate and even more so of a postgraduate program. अच्छा अस्पताल चलाने का मैथमेटिक्स जो है वही डिटरमिन करता है सब चीज़ों को. उसके बाद का जो है वो कोई खास नहीं है. It's the same for an engineering or a NIFT or something. It's really nothing much more than that, I can assure you. Maybe something where specimens have to be stored in some microscopes. So there's been a plethora of reforms. Some have been spoken, some we will cover on that, and tell us what more needs to be done. So on the space and the faculty that you mentioned, libraries are now being, there was a requirement in olden days of examination hall. Removed it. In 2020, we removed it. There was a requirement for books to be counted. Removed it. We are now talking about one subscription for entire, including medical students. So all that flab has gone. So the new maths should apply. That's what I urge. And if we can have well-functioning private hospitals who would like to come forward and and to establish the college part, the so-called college part, it's actually doable. But I do agree that you may have issues about the profit format and Company Act. I have not really understood. I mean, I've not studied that much nicely. But if there are pathways to to take care of that, we will be happy to answer. I'm hearing it for the first time. We are happy to have a meeting on that, how to make it happen. Yes, NEP talks about medical education in general to be, a non-profit affair. We'll see if there is a law of the land allowed somewhere. We'll be happy to find a way. If it doesn't, then it's a question that should go to the parliament. We'll talk about that. We can even talk about that it should happen like that. So that's the first part. Now I wish to highlight a few important points for general sort of comments that have been made. One, this issue of mix of specialities, right? When you look at the OECD countries, then typically they have 70% workforce comprises of specialists and 30% comprises of what they call as general doctors. Okay, they include in that varies, but include general practitioners, family medicine, but also pediatricians somehow in that. Now the issue is that we are moving in a very dangerous dimension in a default mode where we will have a very fragmented system, fragmented by organ systems, by specialists. And I'm bringing you toward general practice and family physician paradigm that I think is a very important point for us to consider, not directly related to the good work that you have done. So trigger is what you said. Now imagine what we are doing now. So we have MBBS, they'll continue to be there. Sir has already equated UG equal to PG seats. 10, 15 years from now, there's more than enough for PGs. Okay. So we'll become specialists of all kinds. So we'll have a few population, MBBS, and a 90% specialists in 2035, 40, let's say. Not acceptable. Because human being is cut up. And today also, you hear it and you know it that we are already having a paucity of where to go as a first line doctor. There we have to admit that the MBBS doctor of the day, and I happen to be one of the previous day, you cannot compress all the knowledge that you require to be a good family physician in these 5.5 years. Although we say we try. I'll tell you the reason. The reason is more science. There's more to learn. More expectations in terms of subjects and the content and competencies and expectations for things that were not so important some time ago, let's say senior care, let's say mental health. So things are getting uncovered. You only have 5.5 years. Out of that, first year is all science, which is sciences, shall we say, although we are introducing early clinical exposure, but that's of a very simple nature. In the second prof, we are teaching how to do history, how to do examination, which is just giving skills. Still long way to start making decisions. That happens only in the last 2 years. Internship has been compromised with this NEET exam, which we bring in, and that has compromised. Very major reform is needed for next to correct this, because our internship experience has, this is in fact a very major flaw that we need to be corrected, and I think we have effort on. The point I'm making is that you need more time. In the UK, there is 6 years, 6.5 years of so-called MBBS, and then 4 to 5 years to become a good GP. Okay, quality GP. I asked one of my batchmates who's been living there, I said, what does the fellow, that 6.5 year fellow, MBBS, he said they become policymakers because they're good for nothing. They need that training. Family medicine in the US is again 10 years affair. तो ये लेके चलो कि ये हमें थोड़ा और एक्सपीरियंस की जरूरत, उसकी वजह मैं बताता हूँ क्या है टेक्निकल. In my times, we were dealing with acute illnesses. So our exposure in that internship and that final 1.5 year would be enough to see a patient coming to us and getting treated the next week or 10 days from now. Please understand what is experience of an MBBS doctor in the final year of learning in medicine. 4 weeks. It's 4 weeks. That's all. That's my window. Pediatrics, 3 weeks. Because the previous one I was learning history taking. I build on that. But the final, when you're all higher level of decision making, synthesis, analysis, not comprehension and recall, you only have that much time. In 6 weeks, tell me what will you learn. Even if you had good quality of care, the most sincere type of internship that I had done, doing night duties and everything, I claim, how much exposure would it give for me to learn schizophrenia, first line therapy to second, hypertension, diabetes, senior care? You don't, or orthopedics. You don't. So please understand, when we are moving from acute care, I can teach diarrheal disease treatment using IMNCI, which you all helped us to an undergraduate, spick and span, 100% capability, no problem, because you can see the result. How to give ORS, how to treat a pneumonia. But then how do you treat me to treat diabetes, which is 15% of India's population and more coming, to go from first line to second line to arrange to use insulin? No way. That continuity of care paradigm is too short a window. This is the problem. Now, I'm elaborating on this because I want voice, because we are not making progress. Our family medicine seats are 39, something like 50. 3 medical colleges still recently were doing this. Now we have requested some new AMSs to do it. It's a challenge. DNB is doing a few family medicine seats. It's very, very thin pipeline. Please, out of the 74,000 overall PG seats, family medicine PG is minuscule, super minuscule. हमें ये सोचना पड़े. Now, there are 2 types of objections to this. One objection, MBBS is general. So I want to know from them, have they sent their sister to MBBS doctor for the first cut before they go to a specialist? कौन जा रहा है आजकल कोई? सरकारी सिस्टम में एब्सॉर्ब हुआ ना एमबीबीएस. आपने कितनी जगह आप देखा कि एमबीबीएस डॉक्टर अच्छी प्रैक्टिस कर रहा है प्राइवेट में? टियर 3 सिटी में भी देखो, खत्म होता जा रहा है. होगा थोड़ा बहुत, बिकॉज वो उतना अब नहीं रहा है. और हम हाइपरटेंशन के लिए भी इंटरनल मेडिसिन और कार्डियोलॉजिस्ट के, दिस इज नॉट द राइट पैराडाइम टू डू इट. Then there are those who say, but community medicine MD is no, but where have you seen MD community medicine running practice? They don't. That's public health. So please create momentum for it. National health policy talks about family medicine, separate line. NMC, one of those clauses, G, talks about promoting family as an extra line. Effort has not happened. In the DNB space, sir, you can do it. In the NMC space, we have to do it. I want us to please think about it, because 30% of our population of doctors at that time should be these, and they should be treated as specialists, but in family medicine, from newborn to the elderly. Elderly care का भी रास्ता एक ही है, general practice. Geriatrician नहीं करेंगे. They are for thinking. You can't have geriatricians to look after 25% of India's population. That's not the way. वो चाहिए क्योंकि हमें साइंस चाहिए, हमें होलिस्टिक नॉर्म्स चाहिए. Internal medicine is another objection. Internal medicine, but you are only adults. You don't look after gynecological problems. You don't do a good job on a 6-week on newborn. तो प्लीज फैमिली मेडिसिन एक जो है उसके लिए प्लीज सपोर्ट चाहिए. यू हैव अ फुल इम्पिटस फ्रॉम द पार्लियामेंट ऑफ इंडिया. एनएमसी एक्ट में लिखा हुआ है, और मेरी से बाकी सब दोस्ती है, लेकिन एनएमसी के साथ मेरी रहता है कि आप मेहनत नहीं कर पा रहे. एंड आई वांट स्टेट, प्लीज डोंट वेट, प्लीज हेल्प डू इट. A, there can be, that is the current norm. B, you don't need it. Okay, if only you can create a system, and that's what we did in the AMS system. So let me give you that little story. At least this message should go. So this was a problem. Family medicine यही हुआ, पहले डिपार्टमेंट बनाएंगे तो कॉस्ट बढ़ जाएगी, फिर हमें परमिशन नहीं मिलेगी, हम कहाँ बनाएं. सो ये रीजन दिया गया. DNB सिस्टम में you don't need, you rotate. Okay, pediatrics gynae, that's one way of doing it. And perhaps that's the only way for us to start. In AIMS system, and 3 AIMS or 4 AIMS have started doing family medicine now because of all this, working hard for the last 3 years. So we told them, and NITI catalyzed that you create a curriculum based on, we expose them to the US system, the UK system, and say best practices. They also rotate everywhere. There's nothing like a family medicine department by and large. They work with general practitioners for a long time. And they have families from the very beginning till the end. And they call it continuity of care. For the first time, I learned the concept of continuity. Continuum is good. Continuity is needed because you don't understand chronic diseases till you watch over a period of time. So based on that, without having to create a department, AIM system, we have got the MD done. So it is under the dean. And there are participating departments. Some departments play more role, others play less role with community outreach. We created that curriculum. I think it's on the web for to see. NMC should perhaps become that because family medicine departments nahi banenge. District ko bana lo. You have a understanding with the district hospital where a lot of general things. We have to find a way. But one way forward is just implement the AIMS, new AIMS, family medicine curriculum, make a beginning, make it interdisciplinary, which is what it is all about. Put it under the dean so that the coordination happens. Exam system also has been taken care of. DNV in any case is already doing it almost the same way. So दोनों को merge करके ये हमें करना होगा. नहीं तो फिर we are visualizing a fragment, a few MBBS who will be doing only policy making at that time. It's a very dangerous situation for our country. And please, to me, this is something that I want us to apply our mind. Okay. Yeah, please take care. Then the other part, which I want us to say as a priority, is emergency medicine. Now, the medical college, when you have undergraduate, you only need a casualty. The governments think that's enough for care. You see, there is also an issue between the expectations from a medical college. From the regulator point of view, NMC point of view, it is only an education hub. From the Janta point of view, it is service. It is secondary to secondary plus tertiary layer where a lot happens. And this disconnect is the one reason why take a medical college. They'll say, okay, medicine department, so many beds, so many seats, and therefore so many faculty. When the workload rises, even when they would increase the number of beds, as sir was saying, they will not give more consultant because NMC says only 3 ही चाहिए कि 6 सीट के लिए 3 चाहिए. हम भूल जाते हैं कि वहां केयर होगी तो बढ़ा दो भाई, सीट बाद में बढ़ा लेना या सीट भी साथ बढ़ा दो, नहीं तो पीजी कर लो. वो जो सर पॉइंट कह रहे थे, disconnect because the finance will say NMC norm में इतने हैं तो हम दे रहे हैं. ये भी डिस्कनेक्ट है. लेकिन मैं उसी पे आ रहा हूं उसके कॉन्वर्स साइड में. To have a UG system in an MBBS, you don't need an emergency medicine department, just as you don't need family medicine department. This is at the PG level. But as a result, what happens? Our emergency services in the medical college are so thin because there is no department. There is one resident from somewhere, 30 so-called beds, belongs to nobody. That's not the way emergency services should run and are running, I mean, in other countries. It's the face of the hospital. It's where the most needy will go. Anybody would go, rich and the poor. So we as BOG had actually made it mandatory to be achieved by 2022. We gave 3 years and new medical colleges to always have it. For some reason, the NMC reversed it, which I think was retrogressive. Some states which were developing such emergency departments with their little extra infrastructure, but people and nursing as departments actually went back because we took this step where the view was UGs don't need it. But what about PG pipeline? Emergency department के PG तो हमारे पास pipeline ही 0. वही 3 department है, 4 department, 6 हैं शायद. So I'm pleading with all of us कि इसमें ये view नहीं लेना. Tamil Nadu was smart. They are the ones who flagged this to us way back. So when the regulation was allowed in 22 medical colleges in one single year, they started emergency medicine program with some, you can imagine, about 120 seats. तो मैं ये 2 चीजें आपके सामने खास करके ला रहा हूं कि इसके बारे में चर्चा होनी चाहिए. They are very fundamentally important. Briefly, we instituted a new program which is needing to be studied, which is called the district residency program. In the second year, all postgraduate students are going to district hospital or equivalent for 3 months. To learn from the context and to be more familiar and more proficient in the diseases that you see there, because one fundamental principle of medical education is contextual learning. You don't learn, let's say, child health without having to at least at some point be in the community, be at the subcenter, be in the family, right? You don't. You learn child health in the ICU of a tertiary care, which is something else. So contextual learning is a fundamental principle. Community-based learning is a fundamental principle. Doing duties and feeling the need in the emergency in the middle of the night is a fundamental principle. You don't learn emergency medicine sitting in front of, YouTube. You don't. So yeah, fundamental. So this principle is invoked that you learn there, you work there, you see nothing is perfect anywhere. वहां जो है उसके साथ करके हमें दिखाइए कि आप अपेंडिक्टमी कैसे रात को करोगे, आप दिखाइए कि फ्रैक्चर कैसे आप ठीक करोगे, वगैरह वगैरह. Second part, which was, you can say, a very important agenda at the same time. When a second year PG, he's a qualified house surgeon of the old times. Okay, or house surgeon लाते थे, surgeries करते. House surgeon is going to the district hospital, then the services will improve because the specialist there now has an extra hand. Just as senior resident and B residents are improving the services. So is second. Third is when 10% of a batch, 1/4 of a batch is moving to be in the district, I can take more seats in the medical college because I have now more spare infrastructure. Got it? Because अब तो मुझे इनको पढ़ाना नहीं, तो 25 वहां जा रहे हैं, so 10% seat बढ़ रहे हैं. So these are the three. One was of course hidden. 9%, 10% seat increase will happen. I don't have to do anything, but they posted out. So they serve, they learn. I like us to study how this thing is doing, because this is a true super win-win program. And reports are that it is useful, but we need ownership of the health department to love these people who have come there. उनको पकड़ के रखो, उनको पढ़ाओ, उनको मौका दो, उनको रहने की जगह दो, उनका इतना मोटिवेशन करो कि वो सेवाएं दे दे. दूसरा है कि मेडिकल कॉलेज शुड नॉट रन अवे फ्रॉम देयर रिस्पॉन्सिबिलिटी टू मेंटर देम, to be in touch with them, to be helping with their thesis little work and so on, which they don't do. They think they're gone, hamari zimmewari. This was not the intent. This was a super win-win situation which should be taken care of, and I think it'll help. Now I'll tell you how much fayda it can do. Let's say today there are 74,000 seats. Let's say today there are 50,000 clinical PG seats. Okay, PG, not super PG, 50. Now, quarter batch is to be in the field, 3 months, that whole batch, right? So let's say 12,000. 12,000 one-year trained postgraduate students are available to go to district hospital. How many district hospital? 790. You add some sub-district, you add another 300, 1,200. 12,000 divided by 10, by 1,200 is 10. 10 residents every hospital will get all the time. Ab 10 chodo. 5 to 6. Continuously, that is a level of increase you have continuously in a district hospital. तो आप सोचिए हर डिपार्टमेंट में एक्स्ट्रा हैंड होंगे, वो 1.5 गुना बन जाए. वहां 2 सर्जन होगा तो एक और मिल गया उसको, या 2 और मिल गए. Make the best of it, right? It's, I think, doing its purpose, but I think the responsibility of the state, the two departments sometimes are separate and they don't see the goodness. We would like the good word to be spread. NMC should be where somebody should evaluate and help us improve. But this is a win-win situation, and please support this. I would especially urge. The reason why we had created, the notion of going up to higher number of seats, which comes from Amrita's study very, very effectively. That's most cost effective. We agree with that. And if you were only to do that for psychiatry seats, from immediately 1,100 seats tomorrow can be added. If only, sorry, I'm mixing up two things. So first part, if you go to 250 seats, as Sir said, it'll already will give so many more UG seats. You give some number. If only from the existing you start saying, give me PG seats, you will immediately get that one. So please look at those numbers, all the state governments, आप उसको करिए. PG को extra अलग से लीजिए. But the third point that I am making is that by keeping this in mind, it is possible to get the super corrections in PG seats. For example, if with the existing norms for psychiatry in the normal medical college MBBS running program, where psychiatry is an essential department, if only every one of them does PG with the same, no change, 1,100 seats can be added next year. ये मैं कह रहा था. तीसरा part है, which means basically we can discuss more if the state government would love to do it. But all between the two of us, what we are saying is even the existing capacities with a little bit of help open up PG seats in a big way and open up opportunities for rapid escalation of UG seats, which is Amrita's main point, without having to add anything. But that should be one of the levers that we should push, and we can talk more about this. 3-year hospital running was essential. That before you start a medical college, for some time the hospital should run. This regulation was brought in because the private sector medical colleges would start without a medical college. Then they'll say we'll make it when the students reach 3rd year, but they don't. Then what do you do? So because medical college is at the heart of मेडिकल कॉलेज आप चलाइए, उसके ऊपर सब करते जाइए, तब लेके आए थे. Now when the government gives guarantee that we'll bring the college anyway, that's the course correction that has now been done. But look at the logic. Don't ridicule some people. क्यों चाहिए शुरू में? क्यों? इसलिए चाहिए कि जब 2 साल तो एकदम से हो जाने हैं तो. और दूसरी बात है कि आपके करिकुलम में अर्ली क्लिनिकल एक्सपोजर इज फ्रॉम द फर्स्ट ईयर. तो इसलिए हॉस्पिटल चाहिए कि चलता हुआ हॉस्पिटल मिले हमें. तो था कि 2-2.5 साल से चल रहा होगा तो फंक्शनल होगा. ऑफ कोर्स इट कैन बी रिफाइंड, लेकिन इसके पीछे ये वाली सोच थी बिकॉज लॉट ऑफ कॉलेजेस स्टूडेंट्स वर नॉट गेटिंग क्लिनिकल एक्सपोजर and then there were issues about closure and the students had to be located in the court cases and so on and so forth. So this had to be corrected. I think last 2 points. One, we would like to know from you, from the researchers, and we'll be happy to partner, what the expectations of the faculty at the colleges are. Because not finding faculty, how can we make it attractive? Those who are faculty members, how can we give them, joy of teaching and joy of work? What is it that would drive it? Is it salaries? Is it something else? Working conditions? How to make it attractive? How to get optimum faculty participation is the key. Your original thoughts on this, new pathways, will be very, very important for us. We talked about raising the faculty age to 75 years. It's already 70. Does it make sense? Will it create more problems? We had opened, this notion of visiting faculty comes up from time to time. कि allow करिए, हम तो ऐसे पढ़ते थे, visiting faculty आती थी. So this has been allowed from 2020. That after the core faculty that is needed to run the hospital, and that becomes the core, you can have visiting faculty as many as you want. In fact, we said 25% तो कोई आता नहीं. There is no enrichment of a medical college teaching from the visiting faculty, which we were told repeatedly कि आप allow नहीं करते. अब allowed है, actually non-allowed कभी भी नहीं था. We are not using it. In fact, state government can say at least 30% faculty visiting इसके ऊपर और आनी चाहिए, so that the core faculty can be offloaded a little bit. But more importantly, with additional faculty, the quality can improve, the joy can be more sessions can be held, the batch size can become small. And incidentally, in medical college, the faculty number is not decided by how many people can be accommodated in the room, but how many students can be accommodated around the bed of the patient. That's where teaching happens. ये भी समझ नहीं आती जो लोग बोलते हैं कि इतना क्यों होता है. Teaching happens in small batches. Even now, I think batch size has gone to 20 and so on, which is not right. It should really not be more than 12 to my mind. When we were students at AIM, we were 5. But that may be a luxury which we cannot afford. 12-10 उसके अराउंड कितने बेड में हो सकते हैं आप ये देख लो. 12 ही हो सकते हैं ना, 20 तो नहीं हो सकते. So that determines the number of faculty. So you do the maths. If you think even now the faculty norms are more than what they need, we will correct it. It's as simple as that. तो किसी को कोई इंटेंट नहीं है, लेकिन well functioning hospital, enough people to do small group teaching, these are the essentials that are needed. I think I'll pause here. So many thoughts, but maybe some other day we will take it forward. By ending by saying, so one need is how to retain faculty would be very helpful. And Dr. Gangadharji and I had a longish meeting just last week on several points in this area. I'll be looking at how to really make teaching as an attractive option. And I think the state governments should rise to the occasion, how this can be done, how to have smart people joining the faculty positions, which is very much needed. And I think we have to, going forward, make this academia, because they are also eventually going to be doing additionally, of course, care, high quality care. So advancement in care, you also need smart people, because it's a huge system, as we already have. And secondly, also some important but relevant research needs to be undertaken by them. And also overall quality. Yes, several points have been made. This disconnect between what you are taught and what you are tested should be corrected. Tell us the points where this needs to be done specifically. Next, we'll take care of certain things. But how to bring in more quality uh, from the teaching system, including the college and the faculty and the clinical material. What is it that we can do? Because there is a criticism that you are compromising quality for the numbers. In policy, whatever little I have seen in life, things don't happen always perfect, in a perfect manner, everything. Then what we would have said was that when we had 387 medical colleges or 300, पहले इनकी perfect quality करेंगे तो फिर 300 अगले 3 medical. That's not how it happens. अब ये हो गया है. Can we find pathways as a nation to make that happen? Right? अब कुछ खुला है, इसको कैसे कर सके? How we all can help? How can the private sector help? And last but not the least, national board, once again, please, there is a huge scope for PG in the private through the national board system in the private hospital system. Sir, thank you very much. You informed me. You're doing a lot. I know Max is doing a lot compared to others. But let me just say the following. There are 6 lakh, at least 6 lakh beds in the private sector. आप एक मिनट के लिए प्राइवेट मेडिकल कॉलेजेस को भी मान लो कि उसी में ही आ गए. There are 7 lakhs in the government sector and the private medical colleges. You national board DNB seats, there are, well, from the overall PG seats, 74,000. This system, okay, non-private bed system is yielding 60,000 seats. And the private side is yielding 10,000 seats. तो कुछ तो correction करना होगा, sir. The way it should happen ideally is the following, that I have this much. Let's say in my hospital chain, I have 4,000 beds. Look at how, if I was to do DNB course, FNB course in each one of them with the current number of faculty, consultants that is, 2 consultants make up for 2 seats per annum. It's as simple as that. How many DNB seats potentially could be done? And you can do a factor of 0.8 and say 80%. That's what you can do. Where am I? We would be finding that we are typically much lower. Let me put it another way. There are 12,000 private hospitals accredited with PMJ system. अब सोचो potential सोचो. Let's say each one of those hospitals will give us 2 seats in any PG department, 24,000 seats. Today the entire DNB system is 15,000 seats. आप समझ रहे कितना potential है? आप 12,000 तो वो तो अच्छे ही होंगे. आप सुनिए, वही मैं कह रहा हूँ कि सब निकाल दो जो सिंपल है, छोटे नर्सिंग होम, वहां भी हो रहा है. डीएनबी ने बना दिया, छोटी छोटी जगह पे भी हो रहा है. सर आप 12,000 तो अच्छे होंगे, भले चंगे होंगे. 2 सीट दे दो हमें, सिर्फ किसी डिपार्टमेंट में, गायनी में दे दो, पीडियाट्रिक्स में एक दे दो, एक किसी यूरोलॉजी में दे दो, एक किसी में भी दे दो. Just 2 seats, 2 new seats as a mission, 25,000 seats. Today DNB has 15,000. So you become, एक मिनट पूरा करने दो, अभी मैं मूड में हूँ आज. 74,000 PG seats next year becomes 1 lakh. और एक और दे दोगे, 2 और दे दोगे, 1,25,000, सारा बैकलॉग ठीक होना जाएगा। आप इस नजर से मैं कहूंगा प्राइवेट सेक्टर सोचे कि मेरे डिपार्टमेंट में 2 कंसल्टेंट हैं, 20 बेड है, कितनी कर सकता हूं? फिर बोलो चलो हम 50% उसका कर, वो नहीं हो। और जो ऑफिशियली बताया जाता है हमें बार बार जब कि हमें वो स्टाइपेंड देना पड़ता है 80,000 रुपया, 90,000 रुपये, वो हमें मुश्किल होता है। हमने कोशिश करी है कि उसको भी कोई सब्सिडी टाइप बने, लेकिन बन नहीं पाई अभी तक बात। पॉइंट इज दैट पर्सन इज ऑल्सो गिविंग यू सर्विसेज, गिविंग 24/7। तो देश के लिए कुछ वो तो है ही ना, ऑफसेट तो कर ही रहे हैं। तो ये भावना अगर आएगी तो बहुत फर्क पड़ेगा। द रियल खजाना ऑफ पीजी सीट्स टू मी एज ऑफ टुडे, and I'll tell you why in a minute, is in the private sector, well functioning hospital। सर दरवाजे खोलो, बहुत पोटेंशियल। एक बड़ी चेन है, उसका नाम मैं नहीं लूंगा, हमने एक बार ही बैठ के हिसाब किया था, उनके पास 4,000 बेड है और वो सिर्फ 400-500 सीट कर रहे थे, उनका पोटेंशियल है 2400 सीट कर रहे, 1800 सीट कर। ये अनमेट नीड है, इसके लिए हमें राइज करना होगा। एंड प्लीज लेट्स वर्क इन दैट फैशन। So I'll pause here, and we need for PG seats is much more, and there the government, the private, because in the government sector the expansion has happened in the last 5 years. These medical colleges are still maturing. वो 157 जो हम बना रहे हैं अभी तक, वो जब तक पीजी में अच्छी तरह से मैच्योर होंगे टाइम होगा, फिर एक डिपार्टमेंट में आएंगे। आपके पास तो फंक्शनिंग हॉस्पिटल है, कार्डियोलॉजी भी है, इंटरनल मेडिसिन है, पीडियाट्रिक्स है, आप कल ले लो सीटें। वो तो अभी बन के आएगा, उसकी फैकल्टी की प्रॉब्लम है। आपका तो अच्छा चल रहा है ना, कुछ और चाहिए ही नहीं, इसी बैच में अप्लाई करो। ये क्वेश्चन। थैंक यू सर।
Thank you so much, Dr. Paul, for a wide-ranging set of directions, instructions to all of us, and I think it's a measure of interest that all of us have stayed for half an hour beyond the allocated time. Thank you very much. Hope to keep this conversation going, and then we will be happy to facilitate, closing some of these feedback loops as and when interested. So please feel free to reach out to CSEP. Thank you.